in South Africa. It's important, this particular topic itself, because as you would look at the series of topics also on our website, both in audio and video format, as well as all of the presentations that are there by our distinguished presenters, that the topics have shifted and changed as the needs arose for us to support the COVID-19 workplace preparedness and prevention campaign under the auspices of the national authorities. So this topic, therefore, is critical, and we welcome you all again for joining us in this particular webinar. I must, at this point, just say thanks a lot to the team and the leadership here at the NIH. That is both the person in charge of the COVID-19 outbreak response team, Dr. Tanusha Singh, who's unfortunately not able to welcome you here today. She has an urgent other NIH commitment to attend to, and also Jeanette Manganye for leading co-leading the training on the COVID-19 outbreak response team, and then to Dr. Samantha Yalu, who has coordinated this particular program. So we've made great strides in making this available to you, and what is critical in the process is having secured free data access, which means zero-rated data for our website, where all of our resource and materials are uploaded after each of these webinars, and you can go and view that. We are in the moment busy formulating a plan to get a learning management system in place as well around the materials on the website. Our materials are also, like this particular one, we do now have 1,000 webinar limitation, a bit of a change in our approach given the shift, as well as when that limit is reached, you can access the live YouTube feed on our NIHSA YouTube channel, as well as the Twitter handle you will see on our slides again at the end of this particular webinar, and I'll play that again. So we're extremely grateful and thankful for our panelists for joining us today, and I would like to just briefly introduce the number of panelists. Our first topic is the long-term cardio-respiratory sequelae of COVID-19. I hope I pronounced that Latin term properly, by Professor Guy Richards, who's ready to share his screen with us. And following that will be Dr. Sandra Fernandes, who will be dealing with neuropsychiatric sequelae and the considerations post-COVID-19 illnesses. And I'm going to ask our presenters just to correct the straining character speaking to you now on his pronunciation of that Italian term. Sorry, that's probably a Latin term. And then thirdly is Dr. Greg Kew, who's dealing with the principles of fitness for work and how it relates to COVID-19. He's followed by Ms. Tia Marie Hofmann, and she'll be dealing with the work capacity, rehabilitation, and functional assessments for COVID-19. And then Dr. Jack van Zyl will be dealing with disability assessments in the insurance industry and COVID-19. And then finally, Dr. Musa Ramansi is going to deal with the medical assessment of an employee returning to work post-COVID-19 in this illness. And so it's quite a full program. I'm not going to say much more, but then to just briefly introduce our first presenter. So that's Professor Guy Richards. Professor Guy Richards is an emeritus professor of critical care and pulmonology at the University of Witwatersrand and the Charlotte Maxeke Johannesburg Academic Hospital. He was awarded his medical degree in 1978, specialized in internal medicine in 1985, and subsequently qualified as a pulmonologist and intensivist. He was awarded his PhD in medicine in 1992 from the University of Witwatersrand and was awarded the Mandela Medal in Gold by the President for Distinguished Service. Professor Richard has twice been the co-chairman of the South African National Critical Care and Thoracic Society Congress and was chairman again in 2015. He's been invited to speak at numerous meetings on pulmonology and intensive care and has given well over 500 presentations at national and international congresses. Today he has authored 11 book chapters, 108 peer-reviewed, indexed scientific papers, and since 1992, Professor Richard has an active role in the guideline working groups of the South African Thoracic Society. He's been chairman of the Pharmacy and Therapeutic Committee at the Charlotte Maxeke Johannesburg Academic Hospital, and is chairman of the Gauteng Provincial Pulmonary Committee of the Provincial Pharmacy and Therapeutic Committee. Now, I think that's a very important introduction for our important guest. Professor Richard, thank you for joining us and making time to share your knowledge and experience on this particular topic. I hand over to you, sir.
Yeah, thank you very much, Ashraf. I will, as you say...
Unmute Professor Richard.
I'm actually not on mute. Am I on mute? I'm not on mute, Ashraf. Can you not hear me?
We can hear you. You can proceed.
Thank you.
Pleasure.
All right. I'm going to be talking about some of the chronic manifestations of COVID-19, which are obviously very critical when we're talking about people who are going to be returning to work. We know that, in fact, it is a very common abnormality that we're actually seeing, and reports suggest that 30% have not fully recovered several weeks after their initial illness, and some of these actually persist for months. It often occurs in physically fit younger people where they have persistent exercise intolerance, they have breathlessness, cough, anxiety, palpitations, poor concentration, that's often known as the brain fog specifically, and intense fatigue, mood swings, muscle and joint pains, headache, etc. And often they will suffer the illusion of recovery only to fall back into mental and physical exhaustion. And many of you who've actually had COVID might actually know or be aware of these types of symptoms as well. In this study, 292 patients were interviewed. At the time of diagnosis, 94% had at least one symptom. So, of course, many of them are mild. But of those, 35% had not recovered at a median of 16 days post-testing, and 26% of those in the aged 18 to 34 years, 32% in the 35 to 49, and 47% in those more than 50 years. And 43% of those that initially had cough, 35% that had fatigue, and 29% that had shortness of breath still had these symptoms at the time that they were reevaluated 16 days later. So the factors that are associated with ongoing health are older age, compared to 18 to 34, with an odds ratio that's double. If you've got more than 3 comorbidities, then your odds ratio also more than double. If you've got a BMI that's elevated to greater than 30, then odds ratio also doubled. And if you've got a psychiatric condition that was preceding this episode, you have a more likely to have ongoing ill health thereafter. So this often, in terms of those that are more sick, resembles the so-called post-ICU syndrome, the PIC syndrome that we've been aware of for some time. And that really means health problems that remain after critical illness. It's present when the patient is in ICU and then often may persist after they're discharged. An important one is ICU Associated Weakness. 50% who stay in the ICU for more than 1 week may take more than 1 year to recover their normal physical ability thereafter. Most studies of patients that have been in ICU report persistent anxiety and depression in 12 months, and some report PTSD, post-traumatic stress disorder, for up to 8 years after they've been in the ICU. And there's a 3-fold increase in the odds of moderate to severe cognitive impairment as well. In terms of COVID, where we know that in the respiratory conditions, chronic cough, lung fibrosis, bronchiectasis, and pulmonary embolic disease are the critical aspects. And this actually mimics what happened with SARS some years ago and MERS, that 30% had a persistent lung abnormality, although in that setting, most of these were mild, and their gas transfer or the ability to diffuse oxygen was in the region of 70 to 80%, where obviously 100% will be normal. And the risk factors for moderate to severe COVID-19 are similar to those for idiopathic pulmonary fibrosis, which is a fibrotic lung condition of unknown etiology. Older age and males are most at risk in terms of that, in terms of fibrosis. And also, of course, the COVID targets the alveolar epithelial cells, like the virus herpes, which has also been implicated in the pathogenesis of idiopathic pulmonary fibrosis. Now, those of you who know lung functions, this is an example of a lung function, and you can see that the forced vital capacity there is 42% of predicted. 42% of predicted, that's less than half. So significant restriction that we're seeing with an FEV1 of 53% and a ratio of 98.7. That's the type of lung picture that we're seeing in many patients who've been ventilated. You can see the extensive fibrosis that has occurred in these lungs over here. Another example of that fibrosis. This is interlobular septal thickening that we're seeing over there with significant fibrosis and even honeycombing that resembles this condition IPF that I mentioned before. So you get an acute or chronic inflammatory process that damages the epithelium of the lining of the alveoli. You then get overexpression of pro-inflammatory cytokines, transforming growth factor beta, TNF, IL-6, etc. You get fibroblast and myofibroblast activation. Then you get excessive collagen deposition in the extracellular matrix, as in that diagram. And you end up then with fibrosis, and many patients are respiratory cripples. This is looking at those that were likely to develop fibrosis. 32 confirmed patients with COVID-19, 14 that developed fibrosis. The fibrosis group was older, 54 versus 37. Their CRPs were higher initially at 53 versus 10. The interleukin-6 was higher, 79 versus 11. Length of hospital stay was 19 days versus 10, and some of them had received pulse steroid therapy. That is not a contributing factor, but indicates the severity of the disease, 11 days versus 5 days, and antiviral therapy as well. So can we prevent this? Well, possibly. It may be reduced by using something like colchicine, which we include in our treatment protocol. It's an inexpensive lipid-soluble alkaloid which accumulates in granulocytes and monocytes and has an anti-inflammatory effects. It also inhibits the inflammasomes and reduces interleukin activation as well. So we administer in acute disease 0.5 milligrams BD and hope that it's doing some good there as well. There is an antifibrotic agent known as pirfenidone that we use to treat idiopathic pulmonary fibrosis, which doesn't cure it, but it actually reduces the rate of development of the fibrosis. It inhibits the production of cytokines, particularly TNF and IL-1, as you can see. And on the right-hand side, it decreases fibroblast proliferation and decreases the inflammation, and then hopefully will continue in this setting to decrease fibrosis. This is not a very good case study, but it is one case study in which the drug was used. A patient who had saturations of 88 to 90%. They were treated at that stage with Illuvia, got polygam and methylprednisone in the acute episode, and then was given pirfenidone on discharge. The CT scan is the one on the left, and the other one on 6 weeks later showed substantial improvement. But of course, you cannot say whether, in fact, that lung might well have improved on its own in that period of time, and we cannot say that it was the pirfenidone. And the trouble with the pirfenidone is that it costs 28,000 Rand a month, and the medical aids will not pay for it because it would be off-label usage as well. Just to mention that these patients frequently have plugging in their airways. This is an ET tube with a big plug within it. There's another one with a big plug within it. And there, over there, and there you can see plugs in the airway themselves. And we just published a paper looking at removal of these plugs and then subsequent improvement in oxygenation when we actually do that. And possibly that, along with something like nebulized heparin, may remove those plugs and also have an anticoagulant effect. Because the acute respiratory distress syndrome that occurs in ARDS displays a typical diffuse alveolar damage pattern, but it also has a diffuse pulmonary intravascular coagulopathy, and that leads to fibrin deposition in the microvasculature and gives you hyaline membrane formation. And the extent of the coagulopathy correlates with poor outcomes. If you nebulize an unfractionated heparin, this limits fibrin deposition and microvascular thrombosis, and in acute lung injury, inhaled heparin reduces dead space, coagulation, microvascular thrombosis, clinical deterioration, and length of mechanical ventilation. So it's anti-inflammatory, mucolytic, and inactivates SARS-CoV-2, preventing cell entry. So we need a study, a randomized controlled study showing benefit, but this is a potential therapy, particularly in hypoxemic patients in the ICU as well. So what else can we do? In patients who come back after discharge or in hospital, who still have persistently elevated CRPs or interleukin-6, if infection is included, then an increased dose of methylprednisone for a few days to assess a response. And we would add the heparin nebulization to see if that might make a difference. And if you've got low inflammatory markers, then again, and they're still in hospital, heparin nebs may be of value with physio and aggressive suctioning and mobilization with rehabilitation, and consider bronchoscopy to assess if there actually are plugs present as well. Just something we've been noticing is that some patients have been coming back with a late ground glass infiltrate. This is not fibrosis, this is a ground glass infiltrate that we see there, and that is steroid responsive. This was a 35-year-old female, BMI was 40, was COVID positive on the 29th of the 6th, was admitted from the 10th to the 18th of the 7th, and then discharged subsequently on prednisone. The CRP was initially 55 and then decreased to 11, but was readmitted on the 24th of the 8th, which was 6 days after discharge. The SATs were dropped, and there now is a new ground glass infiltrate and administered higher dose steroids with a significant improvement thereafter. So myocardial injury, one of the factors that we had to be talking about. This was 39 autopsies where pneumonia was the cause of death in the majority. The cardiac histopathology did not meet the criteria for acute myocarditis, but they actually did see virus in the heart itself with quite a high viral load. Active viral replication was noted, but this was not in the myocytes. This was specifically seen in the interstitial cells and the macrophages. And using 6 pro-inflammatory genes, increased activity was noted in the hearts with evidence of viral infection. So myocardial injury, 20 to 35% of patients had elevated troponin, natriuretic peptides. These are biomarkers of myocardial injury that people might have. Echo during hospitalization demonstrated a preserved ejection fraction with right ventricular abnormalities, and interestingly, left ventricular diastolic dysfunction. So they've actually got good contraction, good contractility, but diastolic dysfunction. And in another study, left ventricular ejection fraction was again normal in 90%, and the most common abnormalities were right ventricular dilatation, usually related to lung injury, and LV diastolic dysfunction as well. And this was shown in another study in New York. And the ones that have caused a lot of worry recently has been a German study, which looked at mild to moderate cases versus healthy controls, and they did a cardiac magnetic resonance on them. The left ventricular ejection fraction was lower. This was sometime after they'd been discharged, and the volumes were higher, and 32% manifested enhancement or indicating inflammation in the myocardium itself and also in the pericardium. There was some potential bias here, and it's possible that not all of these patients may yet have recovered from the acute disease. And there was another study from the Ohio State University that suggested on doing these cardiac magnetic resonance studies that was suggestive of myocarditis in 15% of athletes after asymptomatic or mild disease as well. So the possibility exists of residual LV function and ongoing inflammation with the potential for new onset heart failure and other cardiovascular complications. But it's too early really to say whether in fact there will be long-term effects. And an open letter from 50 cardiologists has stated that the prevalence, clinical significance, and long-term implications of these findings that are seen in the acute disease are actually not known. If there is evidence of an acute myocarditis, and there would be specifically an ongoing tachycardia, refrain from sport for at least 3 months and restart based upon your heart rate, the C-reactive protein, and an echo looking at LV function there as well. Just a point about what the mechanism might be. We've published a paper recently looking at NAD+, nicotine adenine dinucleotide. This is a critical molecule for the activity of another molecule called SIRT1. Both zinc and NAD+ are essential for SIRT1, and SIRT1 is our intrinsic modulator of TNF, interleukin-1, and interleukin-6. In other words, it reduces your inflammatory response. And so if you get activity, hyperactivity of another enzyme, poly-ADP ribose polymerase, that depletes cellular NAD+ pools and leads to ATP deficiency. And remember, ATP is the energy molecule which leads to exhaustion and inability to perform your activities of daily living. And replenishment of NAD+ by nicotinic acid plus zinc have the potential to ameliorate the inflammatory cascade and treat many of the features of long or chronic COVID. And as you can see, many of the risk factors associated with COVID severity are dyslipidemia and obesity, diabetes, hypertension, fibrosis, hypertrophy, etc., ischemia. All of these things, cardiac disease, are associated with worse outcome. And all of them have a decreased activity in SIRT1, and that SIRT1 is mostly related to a reduction in NAD+. So there's the NAD+. All of these factors over here, inflammation of various types, T cells, MARTS activation, SIRT activation, degrades NAD+. And if you have insufficient for actual salvage of it, you actually will lead to decreased synthesis and decreased availability of NAD+, with many of the symptoms you get. If you have been mechanically ventilated or are, to try and decrease the long-term complications, you must prevent ventilator-induced lung injury, and that means looking at appropriate peak and plateau pressures, tidal volume, driving pressure. Minimize as far as you can the oxygen requirements by recruitment, using modes such as APRV. I realize that many of you are not intensivists, but just there may be one or two in the group as well. Avoid fluid overload, make sure the patients don't get edematous, mobilize people early, breathing trials to get them off the ventilator early, and minimize sedation as well. It's obviously difficult in a busy ICU, and isolation procedures interfere with usual care, but it's still worthwhile to actually do it. When you've been discharged after you've been ventilated in particular, then it's recommended that one should do a chest x-ray and saturation 3 months post-discharge for those with moderate to severe disease or with persistent symptoms to see whether in fact they have residual lung deficit. So our therapy currently for long COVID would be nicotinic acid, that's vitamin B3, at 35 milligrams daily. It can cause flushing, but it's not particularly important and minimized by eating a food. Zinc, 5 to 10 milligrams daily. The vitamin C, well, that has an antioxidant effect and may be of benefit. And vitamin D is an important one as prophylaxis as well, because it does decrease the binding to the ACE2 receptor. And in a number of recent studies, vitamin D repletion or being replete in vitamin D is associated with much less severe disease if you actually do get COVID as well. So these actual agents, these agents I've got down here would also be of value to take prophylactically if you haven't had it and you are in an area where there is high risk for COVID as well. So I'm going to end there, and thank you very much for listening. And I'm prepared to answer any questions if there are any that people would like to ask.
Thank you very much. That was Professor Guy Richards. Professor Richards, thank you very much for your contributions. Yes, thank you. The questions would be in the Q&A box. And some of the panelists, the NIOH internal panelists, have also been looking at the questions, and I'll encourage all the other presenters when they're not presenting just to look at the questions and answer the questions that you see is important to look at. So thank you. That was Professor Guy Richards looking at the long-term cardio-respiratory sequelae of COVID-19, and Professor Richards is a pulmonologist and Director of Critical Care at Wits University and CMJAH. I'm now going to introduce Dr. Sandra Fernandes, a neuropsychiatrist at Tara Hospital. The topic is neuropsychiatric sequelae and considerations post-COVID-19 illness. And by way of introduction, Dr. Fernandes is a psychiatrist since 2002 and employed at Tara Hospital since 2004. She is a registered neuropsychiatrist, a subspecialist with the Health Professional Council of South Africa since 2016. In addition to managing a specialist neuropsychiatric ward and a specialist outpatient clinic at Tara Hospital, Dr. Fernandes manages 2 isolation wards for persons under investigations, PUIs, and a dedicated COVID-19 ward. This involves managing mild to moderate patients with both COVID-19 and psychiatric illnesses, as well as other medical comorbidities. She has been very active with the setting up of COVID-19 policies and protocols, and has set up and manages a designated COVID-19 ward for psychiatric inpatients. Dr. Fernandes is chair of the Surveillance Hospital Committee, I think at the hospital, and co-chair of the Tara COVID-19 Response Committee. She's also the chairperson of the Policy and Procedure on Incapacity Leave and Ill Health Retirement, the Pillar Committee. She's currently working on assessing the medical comorbidities of staff and making recommendations on alternative accommodations if necessary under COIDA. Thank you very much for joining us, Dr. Fernandes, and for sharing your knowledge with us. If you could share your screen, I'll hand over to you. Thank you.
Thank you. Good morning, everybody, and thank you for this opportunity in sharing some of my thoughts in regard to this very interesting topic. So if I can just start by having a quick recap in terms of where we are globally. So we know that about 2 days ago, we had surpassed the 1 million death mark globally. And South Africa has done remarkably well in consideration or in comparison to other countries. We have, though, all been globally affected by this pandemic. We certainly have had a shared experience, and it has affected our country and our world in unimaginable ways, and it has certainly devastated the economy worldwide. So we have received a number of warnings over, hundreds of years over what was potentially to come. There have been documentations around the both physical and economic impact of pandemics and epidemics, and definitely the mental health effects have also been documented historically. Now we know that humanity has had to deal with viruses, bacteria, and parasites since the beginning of time. We have to coexist with them. And if we think back, or if we read about it, as far back as Athens in 490 BE, they were devastated by typhoid fever, which in fact resulted in military advantage of the Spartans in the Peloponnesian War. And likewise, the Black Plague and the Black Death certainly devastated numerous parts of Europe many years ago. Now, we've learned a lot and have come to hear of the mental health effects in various pandemics, and in particular, the Spanish flu. Now, not only during the 1900s or 1918 to 1919, did they have to contend with the devastation of World War I, but they also had to contend with about 50 million deaths worldwide. And interestingly, this particular pandemic, an H1N1 virus of avian origin, in fact resulted in about 4 waves in presentation in the United States alone. But it's also historically noted that various neuropsychiatric sequelae were seen in people, from sleep disturbances, depression, dizziness, difficulties in getting back to work once there was resolution or symptoms have abated. And at that same time, they were kind of highlighting also the fact that there were other neuropsychiatric presentations, whether it was from the Spanish flu or other viruses, in that encephalitis lethargica also coincided with the Spanish flu. There have also been lots of other outbreaks. We've learned a lot from the SARS epidemic in 2003 and MERS in 2009. And it is documented that many people were affected psychologically and psychiatrically, some actually having effects up until 2 to 3 years post the outbreak. And in particular, healthcare workers were at high risk for the development of further long-term effects from the virus. Now, we know that various presentations are documented, from more acute cerebrovascular events and to other documented presentations. Now, I just wanted to very briefly remind ourselves how this virus and the stages of this virus, I don't want to spend too much time, but it's to really kind of give us an idea on the progression of the illness and then the long-term effects of this virus. So we know that initially there's an early viremic stage, followed by what might be predominantly a respiratory phase, and then the development of what's come, we all know about, the cytotoxic or cytokine storm. And all of these phases are associated with various clinical symptoms and clinical signs that would progress from one stage to the other. Of course, the cytokine storm being much more evident in the critically ill of the population that has COVID-19. So initially, we have an innate immune response with the production of various cytokines and interferons, etc., followed by more adaptive immune response, which allows the involvement or the production of T cells with a cellular response and certainly an antibody response. So just very quickly to highlight it, you can see that initially during this infective process, you have a huge spike in the virus, detection on PCR, and you can see that the cellular response is a little bit more delayed, but much more longer lasting, and with the late production of antibodies, in particular your IgG. So why is this important? Well, the level and duration of infectious virus replication is important, and viral RNA tests have been used as a marker of infectious coronaviruses in the past. A lot of work was done during the SARS-CoV viral infections, and during that time, a third of patients, in fact, were found to have viral RNA up until 4 weeks of being infected with the SARS virus. Now, in regard to SARS-CoV-2, it's a little bit more poorly described. There aren't that many documented publications on it. However, it has been thought to have a median duration of viral shedding, starting anything from around the 8th day of post-infection, up until about 20 days in survivors, and the longest being around 37 to 42 days. Now, we know that there's been a lot of debate around whether SARS-CoV-2 is actually neurotropic, and it's important to bear this in mind because it makes us think, well, is there a post-infectious kind of neurological, neuropsychiatric phenomenon complications that we need to look at? Now, we know that there are 7 coronaviruses that primarily cause respiratory symptoms and relatively mild symptomatology. However, 3 of them have actually been shown to infect neurons. The 3 that I've highlighted in yellow, and 1 of them in particular being SARS-CoV-1. So this is important because the SARS epidemic in 2003 certainly brought much more, or has given us much more information. And as I've said, there is quite a lot of debate around whether the SARS-CoV-2 virus is neurotropic from the time of infection. So it's thought that there definitely are possible hematogenous spread of this virus, and that definitely there does seem to be strong evidence for the fact that there is direct invasion, as we know, through the ACE2 receptors on neurons, glial cells, gut epithelial cells. We know that SARS or COVID-19 disease is a multi-organ disease. but that this invasion through the ACE2 receptors is particularly involved in the olfactory neural pathways, providing a direct neuroinvasion and dissemination potentially into the brain. There are other mechanisms that people have looked at, and those essentially involve things like the host anti-SARS-CoV-2 responses, which basically result in the blood-brain barrier being quite permeable with inflammation and stress autoimmune processes. And there are secondary immune dysregulated responses, which in themselves cause chronic sequelae in the hypothalamic pituitary axis, resulting in the activation of various steroids and the release of various steroids. Over and above this, there's also been a lot of talk on whether there's a gut microbial translocation of the virus, what's been termed as the gut-brain axis. So what has been noted is that about 40% of patients actually have GIT symptoms from the time of infection, and that some of them actually go on to shed the virus in the stools for up to 5 weeks post-infection. It's also thought that there might be kind of a lymphatic drainage system from the microglia in the brain via perivascular spaces, once again via the olfactory system into the nasal mucosa. And there's also infection of endothelial cells lining the brain vasculature. Now, over and above the mechanisms and the organic mechanisms that I've highlighted, both the indirect and the direct ones, there's various psychological sequelae. We've come to know of numerous factors that are involved, from social isolation that many people experience, loss of work, economic impact, etc. But healthcare workers and frontline workers have certainly been at very high risk because of the exposure to ongoing stress, both physical and psychological, high intensity work. During the SARS epidemic, what was noted is that many healthcare workers still had burnout 1 to 2 years post the outbreak, and that PTSD was very high, especially amongst the female population, and depression as well. There is a ratio of about 4 to 1 from females to males. So there's lots of risk factors that are involved in relation to healthcare workers and frontline workers. Now, unfortunately, there are many unanswered questions. It's still a topic that's evolving. We don't know a lot about it. We don't even really know accurately the proportion of both neurological and psychiatric complications. We don't really know clearly the proportion of central nervous system to peripheral nervous system manifestations. So the difficulty with this is that there doesn't seem to be a united kind of multidisciplinary work approach in order to be able to gain more knowledge on this particular topic. Now, in regard to neurological presentations, if I might touch on it briefly, there was a Spanish study done in Barcelona looking in particular at admitted patients, a cohort population around 820 or so patients who were COVID-19 positive. And what they found is that 57% of them had at least one neurological symptom. This figure was a little bit higher than some other publications that you might find. And there was also another multi-center European study looking at predominantly mild to moderate infection, and they found an overwhelming sense of raised or proportion of people that had an altered sense of smell and taste, hence potentially highlighting the neuroinvasion of this virus because of its retrograde axonal migration through the olfactory bulb. How they actually found this out was that during the SARS epidemic, they in fact took transgenic mice. They inoculated the mice intranasally, and what they found is that there was, in fact, the axonal retrograde migration of the virus and dissemination in the brain. Subsequently, they then took these transgenic mice and they ablated the olfactory bulb, and then they once again re-inoculated the mice with the SARS-CoV-1 virus, and they found that there was no dissemination in the central nervous system. So a lot has been gained from the SARS epidemic, and lots of thinking around that there might be direct neuroinvasion. But various other presentations have been noted from cerebrovascular events, such as Professor Richards has highlighted, and then various other things like altered sensoriums quite acutely, sleep disorders, etc. So some of these presentations are centrally driven from, for example, delirious states, especially early on, seizures in people that are much more critically ill, and then in various forms of encephalopathies. And peripheral nervous system also seeming to be affected with cranial neuropathies, most likely as a result of afferent nerve of the vagus nerve, for example, with again retrograde progression due to the gut-brain axis, resulting then in the progression of that virus via that particular pathway, affecting various cranial nerves and various other presentations too. Now, depending where you actually look at the literature, there are some difficulties because there are definitions that are not very clear around whether people have probable illness, where they have SARS-CoV-2 positivity on PCR and in CSF, and they also have other peripheral constitutional symptoms and various biomarkers that are positive and laboratory markers, etc. And then there are those that have possible illness where there is no positive SARS-CoV-2 on CSF. Now, looking quickly at acute neuropsychiatric presentations, unfortunately, we don't have much data. It is very new, this topic, but there has been a UK-wide surveillance study that's been undertaken involving various collaborative work amongst various multidisciplinary disciplines. And what they found is that there is an overwhelming sense of cerebrovascular events in older patients via various mechanisms such as vasculopathies, endotheliitis in organs. We know that SARS-CoV-2 is a multi-organ disease. There's often an altered mental state, which is obviously quite common with severity of infection presentation. And of course, even as Professor Richards has highlighted, that if you have an ICU admission, that you're much more at risk of developing a delirious or an altered mental state presentation. In terms of, in this particular study that they've done in the UK, they found a disproportionate increase, in fact, in psychosis and in younger people, including neurocognitive disorders and other psychiatric disorders. And this is actually quite interesting and will obviously require much more detailed perspective and longitudinal studies in order to kind of get to the bottom of this. So they've done this under a collaborative network called CoroNerve Studies, which essentially allowed the collaboration between the British Society of Psychiatrists, the Royal College Society of Neurologists, pediatricians, physicians, etc., which I think has meant that they've established kind of a network where the collaboration will allow for further information to really develop and the characterization of novel and rare COVID-19 neuropsychiatric syndromes. Now, we know that ordinarily during any systemic infection, that there are immune responses and there are pro-inflammatory cytokines in the central nervous system. And these cytokines and inflammatory markers essentially cause depression, in particularly in the elderly, and for various reasons. One being that they have reduced immune homeostasis, they have often comorbidities, they might be on various medications, etc. And various inflammatory markers, such as tumor necrosis factor alpha, interleukin-2s, interleukin-6, have in fact been found in some people with COVID-19 who are then presenting with depression and anxiety. As if you see on my slide that in fact, as I've mentioned before, that trauma-related symptoms are in particularly very high in healthcare workers and not as high in the general public. But let's not forget as well that over and above the neuropsychiatric presentations, there are many things that we also need to tease out, such as side effects of medications. A lot of the medications that are part of the protocols of treatment of SARS-CoV-2 or COVID-19, for example, such as steroids, in themselves cause neuropsychiatric presentations, such as mania and psychosis, etc. And there's various other medications that do the same thing. So what are we seeing? Are we seeing a post-viral syndrome, as in Epstein-Barr virus potentially, or a post-viral infective stage? So going on to post-COVID-19 syndrome, or what has become termed as the long haulers, and these are people that have got ongoing fatigue, diffuse muscle aches, depression, sleep disturbance, the brain fog that Professor Richards talked about, impairments in concentration, in memory, etc., and anxiety. Now, I'm sure you've all heard, and we've heard it in the news, that the CDC has reported that up to 35% of COVID-positive people actually have ongoing symptoms. And a study in Italy has shown that a large proportion of patients have persistent symptoms, or they redevelop symptoms after a brief convalescent phase. The difficulty with all this is that there's lack of clarity in regard to agreed definitions of what constitutes a post-COVID-19 syndrome. There's also quite often, if you read in scientific literature, that there's a lack of requiring a positive test for COVID-19, because unfortunately a lot of those people in these publications, they were under lockdown initially, and many of them could not be tested. So the difficulty is, how do we tease all this? And there's also debate around, well, what constitutes the timeline? Is it anything from 3 weeks to 12 weeks post-infection? So are we looking at a post-infectious process, maybe something similar to chronic fatigue or Epstein-Barr virus? Well, unfortunately, I can't give you an answer, because there isn't an answer. It's too early. It hasn't even been a year that we kind of have been living with the effects of this pandemic. And the difficulty with this topic is that often there isn't any pre-existing functioning of people that's actually available. We don't know about their previous pre-morbid states, whether they were on medications, etc. So there are lots of unanswered questions. So quickly, we can divide. We've got lots of past pandemic experiences. We can think about that we have acute presentations, which would be more organic in nature, the more cardiovascular, respiratory, cerebrovascular events that take place, and then to more subacute and chronic presentations that we find. Now, not everyone goes on to develop a post-COVID-19 syndrome, but those that do are certainly going to pose an interesting effect on the economy and certainly in the workplace. So how can we manage this whole process? And my take on it is that we need a whole patient approach. We need to have a multidisciplinary approach. We need to ensure that we have a holistic way of doing clinical assessments with full histories, examination, looking at the symptoms, making sure that we have investigations that will correlate to the presentation of the neuropsychiatric presentation and the severity of those abnormal biomarkers, for example, that we've come to know, such as D-dimers, procalcitonin, etc. And we need to ensure that the medical management is certainly dealt with aggressively, that comorbidities are managed, that the cardiovascular respiratory system is certainly managed fully. There's an element of self-management too, and the mental health will be very important, because this is where you need continuity of care. One needs to address the neuropsychiatric symptoms, ensuring that the predisposing factors of these people are looked at extensively, such as their personalities, their family histories, past psychiatric histories, coping mechanisms, resilience in normal day-to-day events. And we need to treat accordingly whatever it is that they might be presenting with, such as depression and anxiety. Of course, in those that might have neurocognitive impairment, we need to ensure that maybe we use targeted assessment tools. So very basic things that can be used in their primary healthcare level are things like the Falstein's mini-mental examination, the MOCA, the Montreal Cognitive Assessment, the BNCA, And then failing that, one can do extensive neuropsychological assessments in order to get to the bottom on whether there are definitive areas in the brain that have been affected. Now, I wanted to share with you just very quickly a very interesting case that I currently have in my ward, a young 29-year-old female. She has no known psychiatric history or family history for that matter. She lost her job in July and she decided to travel down to Cape Town to be with a boyfriend. Now, he lives in Khayelitsha, hotspot. She describes being there for 2 months, and during that period, she really wasn't well. She had a fever subjectively. She really felt unwell. She shared a house with other people. One of them had a very bad cough. There was no social distancing, no mask wearing. She remained there for 2 months. She kind of got a little bit better, but not that much more. She decided to come back to Gauteng. On arrival in Park Station, she was completely confused. She found herself in Tembisa with no recollection on how she got there. And a friendly Samaritan lady basically found on the side of the road, took her in, somehow managed to get the name of her brother out of her and a contact number, phoned him. He came, fetched her, and took her straight to Charlotte Makeke Hospital. She presented there with psychotic symptoms. They were new onset. She was tested and she was negative. She ended up in the psychiatric ward. So she was in the psychiatric ward for a week. They decided to transfer her to Tara Hospital for further treatment because of the psychosis. However, on the day that she was in transit to Tara itself, they got the result, a late result from a patient that was in the cubicle with her, they were sharing, who was positive. So on arrival to Tara, we knew there was exposure. She had no contact with anyone. She went directly to the PUI ward. And because of on arrival, the history was very acute. It certainly sounded like COVID, although there were lots, some missing pieces, etc. And we tested her and she was positive. So she completed her 10 days in our dedicated COVID-19 ward. And now she is absolutely well, has no psychiatric symptoms, no physical symptoms at all, and she's fully recovered. So what has happened? My question is, well, I don't know, did she have mild initial illness and resolution, or was she reinfected? Did she have a delirious or potentially a complex partial seizure event or a fugue state on arrival in Johannesburg? She certainly had false negative results, COVID-19 results. Or was she positive all this time, actually, and potentially that she had ongoing viral shedding, which maybe resulted in the ongoing neuropsychiatric presentations that we saw in the psychosis. And she's a young woman too, with no past history. So what is the way forward? So I think the difficulty with all this is that as employers, we're going to be faced with an unprecedented amount of long-term effects of post-COVID-19, an increased amount of disability claims and workplace assessments. I think some of this is being social media driven potentially, and there's some good and positive aspects to that. And unfortunately, we will have to deal with some of the negative aspects. Over and above all this, I think we need collaboration between all our disciplines in order to move the research forward and to gain a better understanding of what we're dealing with. We certainly need to have occupational therapists involved from day one in order to look at the level of functioning of people and to get a sense of what their functioning was even pre-morbidly, allowing for work assessments, getting social workers involved, psychologists and our nursing colleagues, and various other doctors in various disciplines. It is certainly going to be very important to look at the detailed histories of people, looking at their resilient factors, their personality structure, and how they manage stress. Also looking at pre-existing depression, anxiety, traumatic experiences in the past. The difficulty is that we don't have an agreed structure in terms of the criteria of post-COVID-19. All in all, not everyone goes to develop this syndrome. So we need to make sure that we do not over-pathologize, but that we acknowledge people empathically. So I started by saying with my presentation that we had a shared experience in this global pandemic. And I think what's come of it in South Africa is that the Minister of Health has been very strategic in allowing this experience to also have a positive effect. And that has been to essentially create a unity and a bond amongst healthcare workers in order for them to kind of have a sense of relief and a support structure and fun and just uniting and challenging one another. And you might think that this is silly, but the creation of something like this is actually very important because it's about sharing, having a support structure, and it's also about increasing the resilience of factors of people. And I did say to you that, in fact, healthcare workers are in particular high risk. So it's been quite strategic for the minister to introduce something that's been quite uniting. So in the spirit of collaboration, I'd like to challenge you all out there to unite, to come together so that we can develop robust research that will be of relevance to our country, that will be of relevance to our population, that will certainly contribute to what we know about COVID-19. I thank you.
Thank you very much. That was Dr. Sandra Fernandes dealing with the topic of neuropsychiatric sequelae and considerations post-COVID-19 illness. And one of the key points for me was this appeal for greater collaboration between the categories of specialists in dealing with this new pandemic, the epidemic within our national context, and ensuring that workplace preparedness and prevention is strengthened. Thank you for that, Dr. Fernandes. I'm now going to move on to Dr. Greg Kew. Thank you, Greg, for joining us again on our webinars. And Greg will be dealing with the principles of fitness for work and how it relates to COVID-19. And whilst Dr. Kew prepares his presentation, a brief introduction. Dr. Greg Kew is a registered occupational medicine specialist with the Health Professional Council South Africa. He is currently in private practice and has 28 years of experience and has assisted clients from many different industries. Dr. Kew did his undergraduate medical training at the University of Cape Town, where he graduated in 1986 with distinction. He did his postgraduate training in occupational medicine at the University of Cape Town. We obtained a postgraduate diploma in occupational health in 1992. And Dr. Kew is an associate member of the College of Public Health Medicine, Division of Occupational Health, and an honorary senior lecturer at the Department of Occupational Health at the University of Cape Town Medical School. He's a National Executive Committee member of the South African Society of Occupational Medicine, that's SASOM, and he's also a member of the Technical Advisory Committee of the Department of Labour, which is responsible for updating the regulations for hazardous chemical substances, asbestos regulations, and lead regulations. Greg, I hand over to you. Thank you for joining us.
Thank you, Ashraf. Can I just confirm if you can see my presentation on the screen and if my audio is coming through?
Yes, perfect. Slide is maximized and your audio is perfect. Thank you, Greg.
Great. Thank you so much. Thanks for this opportunity. So we're going to change gears slightly and look at actions before a person develops COVID and look at some of the key principles of fitness to work. And the brief I was given was that I need to address the principles of medical fitness to work generally, and then overlay onto that specifically the links with COVID-19. This is going to be a quick run through and with sort of more of a focus on sort of practical steps. So I'll take us through the 5 steps of establishing a system of certification and then make those links. I'm not going to be talking about medical surveillance. So just by way of semantics, medical surveillance is about screening for the presence of an occupational disease. We're talking about fitness to work here. And just also, I'll make this point in a moment, the focus for the regulations for hazardous biological agents, which is very relevant in terms of COVID, obviously, their focus is not fitness to work. Their focus is on medical surveillance. I'm also not going to be talking about the medical assessment of fitness to work in the case of people returning to work after recovering from COVID that Dr. Romanzi will speak of later. A quick disclaimer, the mandate and instruction was about principles, so it's not going to be all the details, but the slides will have a lot of detail, and the purpose of that is for viewers afterwards to be able to use the presentation by way of reference. So I'm going to work through the slides very quickly just to convey the key principles. By way of preamble, any fitness to work presentation will always have something to say about the law. there are many pieces of law that talk to fitness to work, and in particular COVID, but these four are the ones I wanted to just bring to our attention. The first one is the Occupational Health and Safety Act itself, and the two important components of that would be the duties of the employer and the duties of the employee. We look briefly at the hazardous biological agents regulations, where the focus is on risk assessment and surveillance, the regulations and the Disaster Management Act, which is about protecting the vulnerable, and then the Department of Employment and Labor Direction, where the focus is on protecting workers generally, and especially the vulnerable. So Section 8, as most of you would know, really focuses on a safe working environment. The employer has to put a system in place to ensure a safe working environment, and that there lies an obligation to ensure that employees are fit for duty and fit for work, a system that ensures fit for duty and fit for work. This is perhaps slightly less recognized, but really important. And this is Section 14 of the Occupational Health and Safety Act. And I want to just, our audiences to pause briefly on this and take it in. Section 14 requires that all employees have a duty to take reasonable care for the health and safety of themselves and of other persons who may be affected by their acts or omissions. So you're managing your chronic disease and thereby reducing your vulnerability to the SARS-CoV virus is in fact a duty under Section 14. The other duty, of course, is to fulfill your behavioral controls as instructed. You must not bring unsafe circumstances into the workplace. So it's in fact a criminal act to be in breach of Section 14. So all employees need to be mindful of that. And so for today, perhaps the important thing is about ensuring that you do not unnecessarily increase your vulnerability and bring with regard to your comorbidity in the workplace. The hazardous biological agents I've mentioned, so it's really just for completeness to point out that these are aimed at screening for the presence of adverse health effects and such, in that way looking for occupational disease, not fitness to work. And then the regulations under the Disaster Management Act are really prescriptions that require the employer to adopt special measures, and we'll speak about these special measures for vulnerable employees. They speak of people at the age of 60 or people with comorbidities. And then the direction issued by the Department of Employment and Labor, really under the auspices of the Disaster Management Act. For the purpose of today, fitness for duty, that talks to site entry screening and the special measures to mitigate the risk of vulnerable employees. So that's this background, the legal background, to get us going. So what does medical fitness to work mean? Essentially, it's these two components that are the focal point. They ask the question, is this employee capable of performing the tasks required in the working conditions associated with the job? And with respect to the capability component or ability component, does this employee have the capability to do the work to the required standard in terms of quality or effectiveness? And is this employee able to do it safely without undue risk to self or others? So the standard element includes a quality component and effectiveness component, which might require your assessment of vision, dexterity, strength, endurance, flexibility, and so on. So that's standard requirement to do the job at the right quality and effectiveness and to do it safely. Let's turn our attention to what the fitness to work components of working conditions. And it really talks to this. Can this employee tolerate the environments where certain hazards are there? Sometimes these hazards, remember, it's the legal duty of the employer to mitigate these hazards in the workplace, but sometimes these mitigation measures are limited, such as in underground mines and factories, quarries. So there may still be heat, there may be dust, there may be fugitive chemicals, and of course, COVID, HB, hazardous biological agents. So the fitness to work element of this working conditions component of these two criteria is interested in physiological reserve and the presence of vulnerable conditions. Does the employee have adequate physiological reserve, or are there vulnerable conditions that would impact the ability to work in heat or in chemicals, etc.? And is there any reason why this employee can't wear the appropriate personal protective equipment, such as a respirator? So those then are the inherent requirements of the job to be able to perform the tasks required in the working conditions associated with the job. And these inherent requirements of the job are absolutely fundamental to understanding fitness to work. They are defined by the Code of Good Practice for Employment of Persons with Disabilities as those requirements the employer stipulates as necessary for the person to be appointed for the job and are necessary in order to enable the employee to perform the essential functions of the job. So that's what we're looking for when we're looking to determine medically fit to fulfill the inherent requirements of the job. Now, COVID sits in all of this, but particularly interested in this bottom corner, particularly interested in whether the employee can tolerate the presence or the possibility of COVID in the working environment. And we'll come back to that. I want to make a distinction between fitness to work and fitness for duty. This is not often fully appreciated. Fitness for work is a process where we want to determine whether the employee is able to do the whole job. So there's a medical component where we do a medical exam and we issue a certificate of fitness. There's also, for certain occupations which are very physically demanding, such as perhaps in the mines, perhaps emergency responders, the military, where you may want to include a physical capability test which the employee may pass or fail as an independent component to the clinical medical examination. For fitness for duty also has a medical and a general component. The medical component is perhaps, for example, people who are first responders may be required to be screened medically briefly before being deployed. Say for in an underground emergency, the proto team may need to be screened by a medical person to make sure that they're medically fit to be deployed for that particular operation, and they may then get a clearance certificate. This generally fit component is something that happens absolutely every day in the workplace. People report for duty on an every and any day basis, particularly performing safety sensitive work. The supervisor should do, even if not formally on a piece of paper, but should do a pre-duty checklist to ensure that the employee is fit for duty for that day, and if so, proceed with duties. And this becomes formalized in certain occupations such as drivers and forklift operators and so on, where they may need to actually tick off a pre-duty checklist. This slide also talks to standard Sig Notes. Sig Notes are interested not in the job altogether, but on fit for duty. So a Sig Note essentially says you're not fit for duty, and it's issued under the Basic Conditions of Employment Act to certify that there is proof of that incapacity, that unfitness for duty, and when the Sig Note comes to an end, of course, it means you're cleared for duty. In SARS, for SARS-CoV-2, the ones of interest particularly are the certificate of fitness that we will talk about later today, whether or not you are, or the employee is suitably fit to work in an occupation where SARS-CoV-2 may be present. And of course, every single day, it's legal, it's the law that requires employees to do a pre-duty checklist, which is essentially the symptom checklist. So let's look then at the 5 key steps of any fitness to work program. Step 1 is to determine the inherent requirements of the job, which we've spoken about. Step 2 is to determine the medical tests that need to be performed, the minimum medical standards, and the outcomes management. These are should be recorded in protocols or codes of practice. Step 3 then is to decide who does what in terms of that protocol, what is done by the nurse, occupational health nurse, medical practitioner, occupational medicine practitioner. Then do the testing and decide, medically adjudicate, and then manage the outcomes. I want to quickly pause and revise the key overview of a medical testing program, which will talk to those 5 steps. So typically job positions are assessed in terms of their task-based risk assessment. So what safety sensitive work do they need to do? And then from that, you would determine inherent job capability requirements. You will then look at the risk assessments, both the qualitative and the quantitative risk assessments, and determine then what the hazards to which this job is exposed and what potential effects those hazards might have. You'd also want to consider what hazard tolerance requirements, as I spoke of in the fitness to work slide. So those then are attached to job positions where this concept of an occupational risk exposure profile then would be formed, and I'll talk about that in a minute. And we typically might score those minimum capability requirements and exposure risk values, and then devise protocols in which tests are determined that are required, minimum standards are set, and you want to decide if there are exclusions or restrictions that apply to that job, and you attach particular categories of performance necessary. Now you can do the test and determine fitness to work with all that information in hand. And today, of course, we're interested particularly in fitness to work, but there is in the background the medical surveillance happening in the background here too. So risk assessment, looking at the hazard effects, medical testing based on medical surveillance to identify occupational disease. So that's the other activity going on when you're performing a medical testing program. Right, so let's get stuck in with step one, the inherent requirements of the job and the OREP. And the term OREP is probably familiar to almost everybody who's listening to this presentation. This is a format that I use. Essentially, all occupational risk exposure profiles are aimed at two things particularly. The one, to look at the inherent requirements of the job, and those can be defined, as we've said, by minimum requirements around hearing, balance, vision, clarity of speech, hand-eye coordination, strength, endurance, etc. Those are inherent requirements that would be necessary to be considered from a capability point of view. This here may be that the person's working on ladders, working in heights, confined space, and so on. Those are capability requirements. And on this side, I'm interested in the hazards to which this employee might be exposed, this particular job. Those may be chemical hazards, biological hazards, physical hazards, and so on. Of course, there the biological hazards are. So this is an OREP for a mobile plant operator.
Sorry, Greg, apologies for
Yes,
interrupting.
yes.
There is
Yes.
some indications in the chat box that you're a little bit soft. If you could just move it closer to your microphone, thank you.
Okay, is that any better?
Sounds better, thanks.
Okay, I'll do this then. Thank you, thank you. So there we go. So this one here is a mobile plant operator or a forklift operator. And there we're looking at standards that we want to apply as inherent requirements of the job based on the hearing, balance, visual acuity, etc. And you may want to attach increasing capability requirements or standards based on the degree to which those are relevant for that particular job. So capability requirement standards. Then on the hazard side, you look at your risk matrix, and I'm hoping most folks in this presentation are familiar with the risk matrix. It comprises a vertical limb and a horizontal limb. The vertical limb talks to the severity score or the degree of severity or harmfulness that a given hazard might have. So a noise might sit somewhere here as having irreversible significant health effects, and chemicals can progress from mild effects to severe effects. So mild effects, a low score, potentially fatal effects, cancer, mutagens, carcinogens up here. And the Department of Employment and Labor have suggested that we could look at a category 4, perhaps as a value for SARS-CoV-2 because of its potential to actually be a fatal disease. And this word may be very small, but of course, when you have this presentation and have a look at it yourself, you see the containment categories from the hazardous biological agents. Regulations are often used to help categorize these values of severity for biological agents from 1, 2, 3, and 4. The probability is really about the probability of being infected in that job. And you'll see how we use this tool just now. But those hazard-based severity categories and probability categories will determine the degree of medical surveillance necessary. Question is, what about COVID for everybody in the workplace? Should it go into the OREP? Of course, that might be open for discussion. I would propose that COVID and other community-acquired biological agents which can find their way into the workplace should probably not be part of an OREP. They're part of a circumstance which is inherent in a community and that may drift into the workplace. But if you're a healthcare worker, for sure, now COVID is actually part of your OREP, as would other biological agents. So from OREP to medical protocol, we now want you to determine tests and standards. So quick review, this is the slide looking at what fitness to work is all about. So the tests then would be those tests and standards for the ability to do the job, and those tests and standards that look at your ability to tolerate the hazards of the workplace. So the sort of things that you may want to consider is applying perhaps some sort of a standard in your workplace for all the OREP criteria here: hearing, balance, vision, and the minimum the screening test that you'd want to apply for those particular criteria. You may want to decide on some sort of diagnostic test if the screening test is positive, or at least, sorry, if the screening test finds something that warrants further investigation, and you want to set standards according to the relevance for that particular job, whether it's a relatively low requirement for hearing balance, etc., or a very high requirement for hearing balance. And you can do that for all of the elements of the OREP, including hand-eye coordination and strength, endurance, memory, and so on. So I want to just make the point that these are obviously important for every job, and every job requires you to look at the hearing, balance, vision, etc. for that particular job. But SARS-CoV-2 isn't going to increase your need to have good hearing or good balance or good vision, unless perhaps you in a research setting or in a healthcare setting where good dexterity may be required, but it's not going to be SARS-CoV-2 driven. It's going to be as part of your general job in the healthcare setting. So these ones are not being driven. The capability standards are not being driven generally by SARS-CoV-2. But what about the hazard tolerance standards? Now we're talking about, again, the hazards driving something, the hazards here, perhaps chemicals like welding fumes, biological agents, noise, heat. Typically, the fitness to work requirements are around conditions that increase vulnerability. So these might result in task restrictions or exclusions. So in noise, presence of ototoxins, and non-industrial noise exposure, heat, there are a whole variety of medical conditions you'd want to consider that would increase vulnerability to heat, and the same with biological agents such as impaired immunity and medical conditions that involve hazardous biological agents as target organs. So it's clear then that fitness to work medical assessment for SARS-CoV-2 is dominated by this idea of vulnerability. So let's look more closely at this vulnerability. You'll recall, of course, that vulnerability is about factors that increase the likelihood that the person may experience more severe illness. Not the likelihood that the person may become infected, it's about the likelihood of experiencing a more severe illness. And there's several of these publications out there. The one that possibly you know most about is the CDC, that updated their list in July. Essentially, age over 65, people who live in a nursing home or work in a long-term care facility, and then people of all ages with certain medical conditions. The CDC stratified these by conditions with strong or consistent evidence, mixed evidence, and limited evidence. And then these are chronic disorders with which perhaps every single person in this audience is already at least familiar. But I thought this was useful for the CDC to stratify these by increasing, at least by strengths of evidence. The Department of Health also came to the party and provided us with a list to consider when we are considering vulnerability, and theirs was 60 and older, and all the chronic disorders, etc. So a useful guidance for determining vulnerability. This was a study. Sorry, there are two studies that I wanted to share briefly that help to exemplify these chronic disorders and the degrees to which they increase risk. One on the left was published by Nature. It was published on 8th of July, and provides a very interesting graphic of relative risk. It's relative risk depending on the comorbidity. And on your screens, this might be a bit small, but nevertheless, the general principles I wanted to share with you. This middle line here is sort of a reference point of no increased risk, and then the relatively increasing risk based on this horizontal table here. So twice the risk, 5 times the risk, 10 times the risk. And you can see age is a very clear line from, if you use the reference value of around about 50 to 59, if you're 40 to 50, you have a lower risk. And as you get older, you get a steep increase in risk. Interestingly, males have a higher risk, about 40% higher risk than females. Obesity, increasing risk. And this line here is increasing risk according to socioeconomic circumstances. Socioeconomic circumstances would typically result in those people where the socioeconomic circumstances are more challenged, would be living closer to one another, and perhaps folks would be less well, have nutritional deficiencies. So perhaps that's the reason for that increasing risk, and diabetes and so on. So quite a useful mix. So representation of these comorbidities. I thought this is really interesting. Here, smoking in these 17 million patients, a current smoker has lower rate of risk than someone who never smoked. So I thought that was rather interesting. The Department of Health in the Western Cape did a similar study in the Western Cape in June, and pretty much similar stuff they found. Interestingly, people living with HIV had an increased risk for those who are positive, but that was really a positive or negative. There wasn't an obvious stratification by viral load. It was just if you're positive or negative, there was a clear difference in risk. So where to from here? Does determining the employee's vulnerability to SARS-CoV-2 provide enough information to decide on fitness to work as an independent factor? And the answer is generally no. There may be exceptions, and perhaps some people might pose some scenarios where there's exceptions, but generally, the decision regarding fitness to work requires an understanding of the risks of being at work, the overall risk, and this is a universal rule. So this means that determined fitness to work must understand the risk applicable to the employee's job. So what do we mean now? The general formula for risk looks at the consequence or severity of the hazard to which we're exposed and the probability of being exposed, and you saw this earlier. So the hazard might have a higher level of, increasing level of harmfulness, and the more harmful the hazard, the greater the risk, and of course the increasing probability, the greater the risk. But it's the combination of the two that defines risk. It's consequence and probability. You could have a situation, for example, of very high harmfulness, but in fact relatively low probability, which means your overall risk is actually low, even in the presence of a substance that's very harmful. So to use that logic, a colleague, Dr. Jack Mankies, came up with a really ingenious idea, I thought, which I immediately adopted, and that is to use vulnerability as a proxy for this severity. Because the point, of course, is, if I just go back to this point, is that SARS-CoV-2 could sit anywhere here. There's some people who get SARS-CoV-2 with no impact on their health, and there's some who die, and everything in between. So to try and assign a hazard value to SARS-CoV-2 is really a slippery task. But what we can do is say, well, if you have high levels of vulnerability, we can give you a high score in terms of severity, and then map that against probability. So increasing severity is, in fact, increasing vulnerability equals increasing severity, and increasing probability now gives us an opportunity to determine your risk. So let's have a look at that. This is then the risk categories, which I'll speak through very, very quickly. I see that time is now running short. So we can attach vulnerability levels high and low according to age, functional state, immune competence, body mass index, and male and female. And so using those criteria, attach a very high vulnerability score, high, medium, and low according to how you sit in those criteria. The Department of Employment and Labor gave us a very useful opportunity to categorize probability. They gave us 4 categories of probability. I reworked those into 5 categories. Basically, my 5 and 4 are their 4 and 3. My 3 and 2 are their level 2, and then 1 is exactly the same as theirs. And again, very high exposure probability, high, medium, low, and medium, low, and low. And using those, we can now attach a risk score to every single employee and determine actions as a consequence of those risks. So I'm not going into those details, obviously, but there's a nice flow chart that one can then put up on the wall and then map everybody against vulnerability, against probability, end up with a risk score per person, and then attach actions. So who does this? Just a quick reminder that there are particular requirements in law, so who can do what. And we're talking here about Hazardous biological agents typically would be done by an occupational health practitioner, but in fact, vulnerability assessment is not prescribed by the regulation for hazardous biological agents, okay? It's in fact, anybody can do a vulnerability assessment as long as you're suitably qualified. So it could be done by the treating doctor. So do and decide. Now get on with it, get the job done. And this is a quick flow that talks to that. You can design a questionnaire that asks about these vulnerabilities. This could be done by paper or by digital tool. This is then screened by the occupational health nurse, who then sends, okay, all vulnerability category 1 straight to work. And the vulnerabilities higher than that may need to confer with an occupational medicine practitioner, who then review the questionnaires. They may look at occupational records. They may need to phone the person. Remember, they're not at work yet. May require additional tests, refer to their own doctor as necessary, then assign vulnerability, assign probability, and then fitness to work. If there's no occupational health team, then this could be done directly by the doctor. If the doctor is given the questionnaire, the tools, the doctor can actually do this, and then go to this point of adjudicating. Proceed to work, proceed with conditions such as safe work practices, additional PPE or tight monitoring controls. These safe work practices, for example, more make sure that there's less sharing of equipment and that there's distancing in place, that more additional distancing in place. There may be restrictions required, such as task adjustments, less contact time, exclude from certain tasks, and redeploy to less risky work. So those would be the special measures of which the Department of Employment and Labor speak, and then the actions taken accordingly. And if none of these are possible, then the employee may need to stay at home. So workplace accommodation is not required for these. Workplace accommodation is required for these. So the final step then is to play fair. The Department of Health gave us good guidance on this in their document. Guidance on vulnerable employees. Basically, if the employee, can the employee return to work? If not, can the vulnerable employee work from home? And if not, then institute these leave procedures. So in closing, then bring it all together. The principles of determining fitness to work in the context of COVID are similar to any standard fitness to work program. And we always use the determinants of risk as drivers for determining fitness to work. So you look at both the vulnerability and the probability to determine whether or not the person should return to work or is so-called fit to return to work. And in terms of determining fitness to work from a clinical assessment point of view, vulnerability dominates the picture. High levels of vulnerability do not automatically exclude employees from work. They just require appropriate special measures. So that, I think, is an important wrapping up, is that don't automatically assume because you're a level 4 or 5 vulnerable person that you can't return to work. It depends on the probability of being exposed to the virus at work. Thank you. That's the end of the presentation.
Thank you very much. That was Dr. Greg Kew dealing with the principles of fitness for work and how it relates to COVID-19. And without much delay, I'm going to now introduce Ms. Tia Marie Hofmann, an occupational therapist in Rehabilitation and Functional Assessment Center, dealing with workplace capacity rehabilitation and functional assessments. And I see that you have shared your slides. Just maximize the slide. And as by way of introduction, Ms. Tia Marie Hofmann has a BA in occupational therapy, obtained in 1994 from the University of the Free State, and a degree in industrial economics in 2000 from the University of Tshwane. Her interest includes work of physiology, vocational rehabilitation, and work capacity assessments. She has 25 years of experience in rehabilitation and assessment of workers in the mining industry, and the last 20 years of which was spent focusing on the development of physical fitness standards in the mining industry and functional analysis of physical occupations. Ms. Hofmann developed the rehabilitation and functional assessment, the RFA test battery, in conjunction with Dr. Johan Kielblock. Over the past 20 years, the test system is currently widely used in the mining industry to determine physical fitness to work standards. She's currently the Managing Director of Work Expert, and is responsible for the maintenance, development, and ongoing research of the RFA test battery. The Work Expert issues RFA licenses to clients and ensures quality control of the RFA test system. I hand you over to Ms. Hofmann. Thank you for joining us and sharing your expertise with us. I hand over.
Thank you for this opportunity. I hope everybody can hear me. I think through listening to all the presenters, every COVID case is writing its own story. People are unique, and I think the virus is also quite unique. Now, when you look at rehabilitation and return to work, it's very important that we maximize the fit between the worker, the work tasks, and the work environment. And for this purpose, we introduced the functional work capacity assessments as part of medical surveillance already in 2000, but from 2016, it became part of the minimum standards of fitness. Now, these test batteries, as part of medical surveillance, the aim of them is actually to quantify the medical condition, whether it's low work capacity or low BMI, high BMIs. We need to quantify the impact of the medical condition or health risk into functional terms and in relation to the job requirements to determine then fitness to work. Now, on the COVID cases, when a COVID case is twice negative and the vitals is within normal limits, these cases are referred for functional capacity assessments to determine fitness to work. Just on that fitness to work part, before we continue with the presentation, I just want to explain to you the work capacity assessment, because there's different levels of function. According to the World Health Organization's classification of functions, you get body functions and structures. So the virus will impact on your cardio-respiratory system, and then you have different tools to measure the impact of the disease on body functions and structures. So you can also use your ECGs or a basic step test, but the purpose of assessment on body function and structure level is really to measure the deviation from the norm, and we call it then an impairment. And then you start using your body functions and structures on performance skills level, where there's you need to start getting dressed, getting ready to go to work. And there we talk about the limitations. So personal factors, environmental factors is very important here. It can be barriers to employment, or it can facilitate return to work. Personal factors will be your age, medical conditions, even personality, and also comorbid pathologies. Environmental factors is really where you live. And then performance area work is the last phase before returning to work. And here it's very important that your work capacity assessment measures inherent job requirements. And I'm so excited about Dr. Kew's presentation, because the job is setting the standard to return to work. It's not about the person, it's not about his age or even his pathology. It's all about, can he do his work safely and productively without fatigue? And here again, personal factors, environmental factors are playing a very important role. Easy to return a person back to work if it's an office in work environment, but a different story to place a worker 3 kilometers in a stoping area underground. So your environmental factors can be facilitators, or it can also be a barrier to employment. Personal factors is playing a very important role. Dr. Fernandes touched on the fact that anxiety, post-traumatic stress disorders is going to be also possible barriers to employment. We already see it with the cases we assessed, post-COVID cases returning to work, post-traumatic stress disorders were noted. And also cultural beliefs, personality, motivation, all those factors can be barriers to employment or facilitators. So, according to the DMR's guidelines and minimum standards of fitness, the cardio-respiratory system needs to be able to undertake the physical exertion of a particular category of work. And the respiratory system also needs to take must be able to take the requirements of the the physical performance of a particular category of work. And this is very important when you look at return to work, especially for the COVID cases. The risk of sending people that is not physically capable back to work is that they will be at risk of further infections. This is also very important when we do rehabilitation of COVID cases. Some COVID cases really just need to go back to work, to home and just to relax. So rehabilitation is not always the answer for all COVID cases. Just on heat stress management as well, risks associated with limited cardio-respiratory fitness. If we need to send people back to work in strenuous work conditions, very important that you have adequate physical work capacity to cope with strenuous work. Strenuous work is one of the causal factors of heat stress. Most of the HTSs in the mining industry is only seeing limited cases. So strenuous work is a very high risk at this moment. Low work capacity, premature fatigue, which will impact on the tolerance of PPE, face masks, encapsulated garments. So COVID cases, we need to make sure that they are physically capable to cope with even the face masks they need to wear during the work shift. Safe evacuation, if you have limited physical capacity, you will be suffering using self-rescuers. Self-rescuers give resistance to breathing, so very dangerous to put people with limited work capacity in an underground work environment. Safe work practices is very important to cope in hard work environments. You need to be able to self-pace. And also the health implications, compromising the immune system. So then looking at health risks, and then also how functional work capacities is going to address strenuous work, I'm going to get a bit more practical. So Dr. Kew also touched on the fact that the job is very important. The job is actually setting the standard, and OREPS is extremely important, not only for medical surveillance. OREPS actually determining your rehabilitation goals. OREPS is also determining the functional work capacity assessments, test standards for us. Different jobs have different physiological requirements, and we need to quantify those physiological requirements before we start testing people to determine fitness to work. Now, just wearing a mask and working in a hard work environment penalizes the cardiorespiratory system. Different PPE is penalizing the system. Even mobility requirements, if you walk with nice Nike Air Takis on an even surface, different energy requirements than using gumboots, uneven surfaces. Different work positions have different energy requirements, penalizing the cardiorespiratory system and musculoskeletal system, sometimes in isolation, sometimes in combination. So very important to understand the functional and physical requirements of occupation when you assess people for return to work. So the DMR published minimum standards of fitness in 2016, and according to the minimum standards, occupations are divided in different physiological categories, from very heavy down to roaming type of work. And we develop functional and physical work capacity requirements for each work category. So how we did it is we do a functional job analysis. It's based on exposure to work tasks and also looking at the work environment, and then also special PPE, anthropometric requirements, psychomotor requirements. It's all part of the functional job analysis which we've done for each occupation before we actually assess a person for return to work and before you start with vocational rehabilitation. So according to the numeric rating system, we can quantify we can determine actually the physiological strain responses of each occupation. So if you look at assessment methodology for return to work, as well as rehabilitation, vocational rehabilitation, there's two aspects that actually determine your treatment goals, your treatment plans to return this person back to work. And that is the functional requirements and the physical requirements of the work, and then the type of disease injury you're dealing with. So very difficult for people to rehabilitate a person if you don't know the job requirements. And it can form part of the OREPs, which was mentioned by Dr. Kew. So how we do functional and physical work capacities in the mining industry? We apply objective scientific tool. First, we need to determine whether a person generates enough energy to perform the requirements for his specific occupation. So a person will come to the test center, he will say he's a stope team worker. According to the functional job analysis, we know exactly what is the energy requirements for a stope team worker. So we have two sets of tests. The one is a step test if the workload entails an external load of more than 5 kilograms. And then we have a treadmill test where a person just walks with his full PPE on. And then based on that assessment, we can then determine if a person can proceed to the functional work capacity, where we also have different work simulations. Because as you remember, different work positions, different mobility requirements have all different energy requirements. So if you work, for example, in a stope where the ceiling height is less than 1.5 meters high, you will use smaller muscle groups. Smaller muscle groups requires much more energy. And therefore, you need to assess people also in different work environments and different work positions to determine if they are capable to cope safely with that specific work environment and workload. So our assessment methodology in the RFA assessment, with the RFA assessment, is a work physiology approach. And this, in combination with biomechanical approach, and this is very important for COVID cases because it's a cardio-respiratory function is negatively affected, as well as the cardiovascular system. So a work physiology approach is very important. So we compare actually the individual's actual heart rate during the assessment to work tolerance data, and then determine the actual capacity of the individual for work. We use heart rate because there's a linear relationship between heart rate and oxygen consumption. So I will show you that in the next few slides. So our test standards is we simulate a workload of 30 to 40% of VO2 max. That corresponds to 1.1 liter of oxygen uptake, and that is the minimum requirement to perform manual type of work. Heart rate is uncomplicated, easy to administer, and it's also sensitive for both dynamic and static type of workloads, and it's reproducible. Our test centers currently test about 60 work capacity assessments a day as part of the return to work at the various occupational health centers. So it's a high workload, and we need to work accurately and make sure people have the capacity to return to work, and therefore heart rate is an easy way to use. So our workload is our test methodology is we simulate a very specific workload, as I indicated, the minimum requirement for physical type of work, and we measure the client's physiological effort during that workload. And we use then also supporting assessments like the Borg rating scale for perceived exertion, therapists do clinical observations. So the PwC assessment, just to show you how our assessment tools look like. There's the SIP test, and then there's the treadmill test. People are wearing polar heart rate belts. This is just now before COVID. It is not during COVID. COVID, they test with masks on, and we apply the social distancing. We have a RFA application, so the heart rate of the client is directly loaded onto our web-based software system. There's no human interaction. You just press upload, and all the data automatically pulls through to the software. The software already, the job has been analyzed. We know exactly what is the physiological requirement for that specific job. And the software will then compare the heart rate response to the requirements for that specific occupation. What's also nice about our automatic data capturing system is we have real-time test data. So as we assess the client, the heart rate response are showed on, to the therapist. So if a person exceeds his or her maximum permissible heart rate, we can discontinue the assessment. We don't need to overexert people in a test situation. And as I said previously, some people are vulnerable. They do have cardio-respiratory limitations. Some of them are not sometimes strong enough to cope with the assessments, although we have pre-test procedures as well, making sure people are physically capable to do the assessments. Just looking at the test results, how we will interpret the result is on that specific workload we simulate. As you can see, sorry, on the previous slide, people are wearing specific test clothing. We have a standardized test environments. We have a very specific workload we simulate here. It's about 1.1 liter of oxygen uptake. And on that specific workload, a normal person needs to obtain a steady state heart rate within 3 to 5 minutes. With your COVID cases, they will not reach steady state heart rate within 3 to 5 minutes. They tend to, there's no steady state in most of the cases. I will show you later case studies. They exceed their maximum permissible heart rate, or they will exhibit heart rates of more than 150. I saw Dr. Kew also mentioned beta blockers or medication. Medication can also impact on the heart rate. It suppresses the heart rate to a very low level, and that is also a high risk, especially with COVID cases, because beta blockers will reduce your oxygen uptake up to 15%. So it also makes people more vulnerable for premature fatigue, because our beta block cases are all obese clients. And if you expose an obese client to physical type of work with a beta blocker suppressing the heart rate further, is actually a high risk, especially for the mining industry, where people also need to perform work in work environments complicated by high heat loads. So just to interpret the test results, people that will score above 150 on the physical work capacity test can actually endure physical type of work only for 20 minutes. So if you do light type of work and you can rest in between, that is fine. But for people that work or exposed to strenuous type of work, that will definitely be a high risk for fatigue. And for our people doing very heavy type of manual work, we need heart rates of below 120 for them to cope safely with the work environments and hard work conditions, and also additional PPE. For people performing heavy type of manual work, below 130 is the requirement. And yeah, for moderate type of work, anything above 140 will be fine. So in the functional work capacity test, when a person passes the PwC, she can generate enough oxygen to perform the physiological requirements of the work. We will expose them to different work conditions. Each one of these work samples will also require a specific physiological workload. So we simulate the workload by means of the repetitions, weight they need to handle, but also then we measure the workload against the physiological effort it takes from the person to perform the work. So the physiological effort simulated here is the same as the PwC, is around about 1.1 liters of oxygen uptake we measure. So they wear also polar belts, and we have an application that automatically will record the laps, and then it also uploads directly to our software system. We are just implementing the automatic data capturing system for the PwC is now implemented at most of the RFI centers, but this one is a new development. We are now implemented it at the various test facilities. When we do functional work capacity assessment, we test people on different levels, because if a person just came from the acute rehab team referred for a vocational rehabilitation, they are vulnerable, they do not have a sufficient capacity, so we test them on a level 3 where we only have a 25 endurance component, and as they get better and progressed, you know, we will test them on a level 2 and then a level 1 for return to work. So there's a gradual way of testing functional work capacity for rehabilitation cases. I just want to discuss with you the outcomes of our COVID cases. From the 1st of June to the 17th of September, we tested 695 COVID cases at our various test centers. I must say we've got 18 test centers in industry, so it's not now at one test center. But yeah, we performed 810 work capacity assessments on these COVID cases. The type of assessments, 79% of COVID cases was in-service risk-based medical, so they tested positive for COVID, and then after being tested twice negative, they were referred for a RFI assessment to determine whether they fit to go back to work. 18% were new employees, so they came to medical or occupational health centers as initials, and then 3% was novices. Novices is employees with no mining experience before. We recommended 81% of these cases actually passed the assessments with the first assessment. They passed. 16.7% were not recommended for the proposed occupation or their current occupations, and 1.2% of them were not fit for assessment. So they were a bit more acute and need more recovery time. From the 133 cases who was not recommended to return to work, if you look at the prevalence of risk factors here, 25% of them were over the age of 15. Alarming, 37% of them presented with BMIs above 30. 25% of these cases presented with comorbidities. And then also the physical demands of the occupation is quite important, because as I indicated previously, your work environment can be a barrier to employment. Very heavy type of occupations, 8% of them, the type of occupation we assessed them for were very heavy, 27% were just heavy, and then 36% were moderate, and then also got light, 26% returned to light type of occupations, and 3% returned to roaming type of occupations. Now, if you have a cardio-respiratory problem, just walking to your workplace can be very strenuous. So strenuous work is different for different people. It depends on the vulnerability of the worker. So if you need to walk 700 meters to your office and you have limited work capacity or limited lung capacity, it can be very strenuous for you. We expose these clients to vocational rehabilitation. The rehabilitation programs, in-house rehabilitation programs, some of the centers actually expose them to home programs because of the COVID situation. And the duration of the rehabilitation programs vary from 7 days to 60 days. We had 8 cases that is now past 60 days and not yet meeting the physiological and the functional requirements for their specific occupations. The average duration for recovery time is about 3 weeks. If you look at the data available. Just a few case studies to share with you. We've got a 57-year-old male STOPE team leader. The job is rated as very heavy based on our OREPs. Luckily with us in the mining industry, we do have data before COVID because they were assessed previously as at the initial risk-based medical assessment. So we do have data before COVID. So this person was assessed in 2017. His score at Pwc, his physical work capacity was 118. 118 is suitable for any type of manual work. After COVID, when he returned to work, he was 142. 142 Pwc heart rate response is indicating a risk for premature fatigue, so we could not make him fit for his very heavy occupation. He attended a vocational rehab program. The programs entails that we test the person every 2nd week to monitor progress. So he was again assessed on the 13th of August, score 135. So we could actually see he is definitely improving. And on the 25th of August, a month later, he scored 112 beats a minute on that Pwc assessment, and we could make him fit for his proposed occupation. Comorbidities, he is immunocompromised, but as I said, he performed very well on vocational rehab and he was capable to return to work. Case study 2, it's a 33-year-old male STOPE rock drill operator performing very heavy type of manual work. He was assessed as a new employee in 2017. He again applied for a job at a different mine, again a new employee assessment, but after COVID, and then he scored 161. 161 uptake heart rate on the Pwc is actually a high risk because their oxygen uptake is less than 0.9 liters per minute, and that is an indication of high limited work capacity and actually a higher risk. So he's not attending vocational rehabilitation at this stage because it's a new employee assessment, but they receive home programs sometimes, but not in this specific case because the heart rate is too high and we don't want to jeopardize their immune systems further. So he's recovering, and every 2nd week we follow up and see if he's progressing. On the 17th of September, he was reassessed, but still at 159. So there's no recovery taking place after COVID. We also monitored and saw his BMI is decreasing. The other case study is a loco driver, a female loco driver. We actually assessed her in 2005. In 2004, we started testing females in the mining industry. So she's one of our first ladies entering the mining industry. In 2005, her Pwc heart rate was at 148. We tested her after COVID. On the 27th of August, she was unable to complete the assessment. Coughing, dyspnea, and she shows signs of acute symptoms still. She was reassessed on the 31st of August with a heart rate response of 144, which is actually correlating with the test result in 2005, but she was unable to complete the functional work capacity assessment. She was again then assessed on the 7th of September, scoring of 137. also correlating very well with a previous assessment. When we do functional physical capacity assessments, a 10-beat difference in heart rate is actually a confirmation. She again showed fatigue and upper limb strength limitations on the functional work capacity. She attended a conditioning program on the 15th of September, still 147 on the PwC, meeting her job requirements, but on the functional work capacity assessment, she is still battling to get through. She tested with limited strength and upper limb strength on the 22nd of September. But this person also got an anxiety disorder. And I think the anxiety disorder can have an influence on the functional work capacity assessments. As mentioned earlier, environmental conditions, personal factors can impact on your return to work. And I think that is also one of the factors impacting on her recovery, is because of her perhaps post-traumatic stress disorder. We also to note is the fact that her BMI also definitely increased. Yeah. Okay, just to wrap up quickly with rehabilitation, the rehabilitation framework, I think it's very important to have a good software system to manage vocational rehabilitation, to incorporate your functional work, your job demands in your rehabilitation process, know exactly what the job entails. The job will then determine your type of assessment you're going to use, your type of interventions, but have good statistics on how people perform during your vocational rehab, and also the type of interventions you introduce. So we plan a vocational rehabilitation management framework that will be added to the work capacity assessments. This is just our centers and how it's been all complied to COVID infection control procedures. And yeah, with that, I just want to conclude to say health is the real wealth, not pieces of gold and silver. And I think that is quite true of COVID. Thank you.
Thank you very much. That was Ms. Tia Marie Hofmann, occupational therapist, Rehabilitation and Functional Assessment Center, dealing with work capacity rehabilitation and functional assessments for COVID-19. I'm immediately going over to Dr. Jack van Zyl, dealing with disability assessments in the insurance industry and COVID-19. By way of introduction, whilst Dr. van Zyl is sharing his presentation, Dr. Jack van Zyl is an occupational medicine specialist and senior medical advisor for the Sanlam Group Insurance Scheme. He's a lecturer in occupational health at the University of Stellenbosch and was in private occupational health practice before joining Sanlam 25 years ago. He currently works from Struisbaai in the southernmost tip of Africa, an amazing place, Dr. van Zyl. For Sanlam Corporate Group Risk. He does part-time lecturing in occupational health at University of Cape Town, University of Stellenbosch, and he presents a MAA guides teaching for the Foundation for Professional Development. Dr. van Zyl has a keen interest in indigenous plants and is a nature lover and waiting to be a granddad soon. Dr. van Zyl, handing over to you. Thank you.
Thank you very much. I hope you can hear me well. I'm sitting in the middle of a gale force storm.
Well,
it's very nice
yeah, sorry, your audio is perfect and your slides are sharing, and we hope that the gale force is not going to affect us.
Thanks. Nice for inviting me, and very nice to see some names on the chat box that I recognize. For the time allocated, I'm not going to do like a formal presentation on disability assessment, as you could recognize from the previous two speakers, like FCE and fitness for work, the standards are in place. And if you ask me, how do we assess disability claims for COVID cases, then the answer will be very short to say that it's just as for any other disease. However, nothing is as plain and simple as that usually. So I'll just take you to a few peculiarities of the pandemic. If you can look at the slide, you will see that on the top block there, voluntary private insurance is really on top of the staircase of Social Security. The slide is from the International Labour Office, meaning a lot of things. It means that you can't get secured credit with banks and so on if there isn't insurance and risk insurance. And this is a very highly regulated financial system with lots of rules. And the emphasis is really on sustainability. I mean, obviously, if you take out a life policy, you want it to pay out whenever that the death may happen, being it in 30 years. Okay, so immediately the next conclusion from that statement would be that you cannot insure that which you cannot measure, or that which you cannot make a very good assumption of. And you will see then in insurance companies, there's a lot of actuaries and epidemiology and so on that determine risk, and the premium is really based on risk. So immediately you can see that if you read your policy, that special circumstances like catastrophic incidents, like wars, for instance, will be excluded. So don't have the perception that a pandemic and the peculiarities that are around that is specifically covered in the insurance policy. And by the way, the comments that I made is true for all insurance, be you being in Italy or India or wherever in the world, as we reinsure with more or less the same reinsurers. So what I'm saying is that, of course, if you has got a diagnosis, there's proper treatment, the impairment has been measured, as you heard before, functional capacity evaluation maybe has been done, and you cannot do your work, then it's a valid claim. The expectation, however, if there's that you should be paid for a disability claim where you have to lock down or must isolate is a total different story. And in general, it's not covered. However, in all these, there might be exceptions to the rule. I can remember very clearly 30 years ago when I studied epidemiology and statistics that we debated when the next epidemic is going to hit the world. And we had glimpses of this with the swine flu and the bird flu and so on. And of course, we tell this to our colleagues in the insurance industry, and then some of them, of the insurance people, then created a pandemic kitty, so to speak. In other words, they held some money back, and others maybe had a different approach, business approach to this. So you would have seen in the financial statements recently of various financial institutions that some is making now huge provision for it, and others maybe already had made provision and as perhaps at a liberty to pay a little bit outside the formal contractual rules. The problem is just, of course, that once this pandemic is panned out, what is next? Do we have another pandemic? And that will always be for sustainability reasons that the insurance people have to consider this. So, saying all this, let me talk you through to the normal insurance claims that you can have. Of course, if you die due to COVID complications, it will be a valid claim. In fact, whatever the death is from, except if it's due to that specific exclusions in the contract, like if you're in criminal activity or you're under the influence of alcohol and you drive, or you do hazardous sports that's not covered and so on, then the death claim will be paid. Living benefits, you may remember, and maybe yourself has got some of these policies, like impairment policy, will quantify and describe in the policy contract what they mean by an impairment level. So for instance, if you've got a permanent cardiomyopathy, or you've got end-stage lung disease or renal failure, whatever, if it's caused by COVID, of course it will be a valid claim. The same goes then for disability and severe illness. Severe illness usually don't particularly cover a specific diagnosis, except in diseases that we know the incidence and the prevalence of, like myocardial infarction or cancer and so on. But I remember clearly some 10 years ago when we wanted to cover things like Ebola in our severe or dread disease cover, that the reinsurers wouldn't allow it, because it will not be a sustainable practice to cover that specific thing. Disability impairment, disability cover. May I just remind you that we talk easily about disability, but the cover particulars, the different contracts may differ, and that will determine if a claim will be valid or not. I will get back to that specific thing. And then coming back to what we've heard earlier this morning, there's a lot of indirect problems that we see due to the pandemic. Firstly, there's a delay in normal treatment processes, normal care. Diabetics can go uncontrolled. The knee replacement doesn't happen, and so on. It all delays and lengthen the time of absenteeism and the time that the patient will claim for. So on top of the very high claim incidents that we had in the past years, this is on top of this, and it make it even worse. Again, the psychiatry thing, it's not to be smiled upon. We already see the things that you've heard this morning. People claiming and not returning to work due to the effects of the COVID and the isolation period and the lockdown. And we even see it in our workers. I mean, suddenly we had like 12,000 workers who has to work from home. We see it in our people that's doing work that we don't normally see these claims from, like HR, IT people that's been on tremendous stress to get everything rolled out. Even on our own unit of claim consultants, that they're under a lot of stress. And then, like in the first lecture, long-term complications, we still don't know everything, but of course, if it's a permanent complication, that means you cannot return to work, then it will be a valid claim. And then just lastly, there's a lot of ethical stuff that we had to negotiate. For example, is it now ethical to send someone that's due for review on his disability claim to now be examined? Is it on the new business side, can you send someone for a lung function test or for ECG in these circumstances? Is it ethical or not? And these are serious things that we had to negotiate. In fact, we shut down the new business part for quite a long time. Going over to the underwriting, I'll come back to the disability just now. Going to the underwriting side, if you now have to apply for disability insurance, you will suddenly see that it's a little bit of a different ballgame, especially if you apply like some of our professionals do. for disability cover, temporary disability cover, with a short waiting period. And I'm talking a week or 2 weeks or a month, that the criteria is much more stricter, especially a thing like obesity, where the insurance industry has been quite relaxed about, but now we see the risks are very high. And then secondly, you may remember that this is not the first epidemic we had, and that we had problems with the HIV epidemic, how to handle it, because we haven't had statistics to work with. So I believe at the moment, if you apply for a short-term disability product, some companies will put an exclusion on to say that they're not prepared to cover COVID. Others say, yeah, we'll cover COVID, but only if you admitted at a hospital, and so on and so on. So you can just see the tremendous effect this has had on the normal running of the insurance system. May I just remind you about disability insurance, that you get lump sum. This is the permanent disability. And the problem there, of course, is all these long-term effects that we have. We've heard about things like brain fog and myocarditis and maybe cardiomyopathy and renal damage and so on. If it's a lump sum product, it only pays where there's certainty of permanency. And it's very difficult, just like in psychiatric claims, to determine when is a claim now permanent or not. For the temporary claims, it's far easier. However, especially on the employee benefit side, we've seen an epidemic of claims in the last couple of years. Maybe you're aware of it, but the premiums has been hiked tremendously just to keep up with it. And I say something more about that later. So what happened is that if you buy a short-term disability product with a short waiting period, the shorter the waiting period, the more expensive the product, of course. And the longer the waiting period, the cheaper you can get the product for. So in the employee benefit sphere, like most mines or construction companies would have, the waiting period is usually around 3 months. Okay? And thus far, we haven't seen that many COVID claims come through. But saying that, remember that we've usually got a lag time, because the HR people has also been locked down, and the pension fund people has been locked down. So we usually see a lag time before the claims get to us. Let me go to the next slide. Just reminding you that the disability product is usually a diagnosis of a disease, the level of impairment, and that, if you can read at the bottom, and then you evaluate the disability. And you compare that with the job description that you have, and then you look at the contractual facts of the specific policy that a person has taken up. So you will see nowhere in this that they address lockdown, because nobody really thought about the idea. But because you can't measure it, it's usually not in it, and it won't be a valid claim. Disability assessments usually look at the diagnosis and the prognosis, if there's maximal medical improvement after optimal therapy, and then the impairment evaluation and functional capacity evaluation, like we've just heard. Compare it with the task, see if you can adapt the work place or the job, alternative jobs, and then compare it with the clause and get a conclusion for that. and it must be legally defendable in a court of law. Can I share with you some stuff that I've seen or that we've seen? And really now I must warn you, please, that all these data has got a tremendous lot of confounding variables in. There's a lot of bias. You cannot compare one portfolio with another portfolio, even within a specific company or with another company, or extrapolate to others, to the general population. This is just one example to give you some kind of feel of what is going on in this industry. So you can see on the death and funeral claims, March to June, we had that amount, it's about, say, 12 million paid out. And this is on the one portfolio. And for the month of August, you'll see it's nearly reaching 100 million. Now, one of the important biases there, of course, is that the death certificates we get just say unnatural and natural. It's only where the people specifically in the claim form, and that being the family, will state the diagnosis that we can count these things. But in general, we've seen a spike, much more that we see normally. And we sort of suspect that the death rate might be higher than we all recognize. And this is a similar pattern that the Medical Research Council has published some data on. On the living benefit side, and this is a portfolio where people did pay for even for lockdown and when you cannot work. Just look on the left-hand side, and you will see regarding occupations that 88% was for medical and health services. Okay. But again, saying that this is a reflection of what kind of people buy this specific product, and you cannot extrapolate it to other people. Apologies, on the right-hand side is the death claims, and that's of course a total different kind of scenario. If you look at the age spread, and again, the biases are there, you will see the living benefits that we see is around 30 to 40. That's people were the most active, and perhaps also on that group buys the most insurance. So we don't have ratios or percentages. On the death claims, it's more the typical pattern that you will see in your ICU, or that's reported in the press as well. The gender for the living benefits, it's more or less the same. And of course, in death claims, there's more males. Geographical spread, really just have a quick look. That could just means that more people in Gauteng, for instance, buy the specific living benefits and death policies people buy in different areas of the country. Unfortunately, without proper denominators, it's impossible to work out ratios. Then lastly, I just want to say something else, is that in the last couple of years, we've had a real epidemic of disability claims. And lo and behold, it hasn't got a relationship with any epidemic or any disease pattern, but the economy of the country. And one or other time we can debate this, why it is so, but you're all aware of the influence of motivation, for instance. I mean, you get people that's severely impaired but still want to work and do work. Okay. So we have seen increases that is just out of the ordinary in the last couple of years. And now on top of this, we've got the epidemic. Just want to highlight the unemployment rate as the one indicator which we determine our expected claims on. this is now 2016, just to give you a perception how it was in the past. In the first quarter, you know, it was up to 30%, and now with COVID on top, the broader definition is up to 40%. So it is a real catastrophe that's going to happen, or is busy happening. In our industry, we basically live during the day COVID and sleep at night COVID. Just to conclude, disability evaluation is a thing that's based on certain criteria. Unfortunately, what we experience is a lack of understanding of what the assessors would want. And we've come together with some of the people of UCT in occupational health and developed an online course that's now finishing its pilot phase. And I will, if you're interested, you can do it online very soon, and that will be introduction to a more formal disability or impairment training. Thank you very much. I hope you heard me well.
Yes, thank you very much. Your audio was perfect, Dr. Van Zyl. Thank you for your contribution. And if you could just unshare your slides. I'm now going to introduce to you Dr. Muso Ramansi. Dr. Ramansi is going to deal with medical assessment of an employee returning to work post-COVID-19 illness. Dr. Ramansi, while you are sharing your slide, Dr. Ramansi is current Chief Advisor, Occupational Health ESCOM, and the appointed medical practitioner at Coburg. He is a qualified occupational medical practitioner with an LLB and a Master in Sports Medicine. He has 21 years experience in occupational health, major interest in COIDA, fitness for duty assessments, medical incapacity, and disability assessments. He's currently a guest lecturer at the Wits School of Public Health and the School of Health Systems and Public Health at the University of Pretoria for the postgraduate diploma in occupational health. He's a former lecturer at the Wits Department of Anatomical, tripping over my tongue there, a Department of Anatomical Sciences at Wits University and the University of Northwest Department of Nursing. He's a former Chief Medical Officer at the Compensation Fund under the Department of Labor and a Senior Medical Advisor at the Northwest Department of Social Services, Arts and Culture and Sport. He was the convener of the Technical Committee on Occupational Diseases and Regional Medical Advisory Panel under the Compensation for Occupational Disease Act, COID Act, which developed the circular instructions on the compensation for occupational diseases. Informing part of his experience in sports medicine, Dr. Now I've got my names, Dr. Ramansi, apologies, my name's mixed up. It's developed being the team doctor, of Jomo Cosmos Football Club with regard to his sports medicine experience, and in serving as a venue medical officer at the Bafokeng Royal Stadium in Rustenburg during the 2010 FIFA World Cup and the 2013 CAF tournaments. Thank you, Dr. Ramansi, for sharing and joining with us. I'm handing over to you.
Well, thank you, Ashraf. Thank you, colleagues. I see that I'm the last one. And coming from ESCOM, I was supposed to be the last one because if that was not going to happen, we're going to lose Shed. Colleagues, I'm going to give you what we've done in ESCOM. And I'm going to do that through a case presentation. When we started, when we realized that there's a possibility of a pandemic, which was in December, we started preparing ourselves through our disaster plan. And by February, before the first case, we had already our plans in place. And we had our first case on the 18th of March. So that was immediately after the national disaster was declared. And it was a non-work related case. even though before that we try to make sure that we educate our employees to make sure that they observe necessary protocols. And by the time the national disaster was introduced, we in a way already had things in place. And one of the things that we did was to make sure that we do have a performance indicator regarding our workforce to say, when are we going to get worried when we have a COVID-related occupational COVID incidents. And our indicator was if 0.5% of the workforce contract occupational COVID, then it's going to be an indicator for us to start making plans. We are an organization of about 45,000 employees. And to date, we have 1,884 employees who tested positive, which is 0.4%. And we have 1,707 employees who have recovered. So our recovery rate is at 91%. And we have got 27 deaths. And out of all those numbers, 111 were occupationally acquired. And that was 0.02% of the employees, and 100% of them have recovered. Fortunately, no occupationally acquired COVID cases. We've got zero harm. Basically, we are saying nobody died from that, and all of them have recovered. So I'm going to present a case of one of our employees. It was a 52-year-old male, essential worker. So what we did is that we categorized our employees in 3 categories. It was essential workers. It means that it's employees that were expected to be physically at work during the whole pandemic, irrespective of the level of the COVID or the level of intervention from government, that is the level of lockdown. And the other group was people who were expected to come as and when needed. And the others were those that worked, those that were working from home. And the guy didn't have any more comorbidities. What happened is that on the 11th of May, he was diagnosed with COVID. And our protocols were, if ever you are diagnosed with COVID, irrespective of which category you belong to, you are supposed to report. So all employees, if ever they tested positive, they had to inform us, either the medical center and or the HR or the manager, whoever that they are able to communicate with. And every case was supposed to be confirmed with the lab results. So we will never record any case without the results. And all the cases were registered under internal case management so that we must follow up. And all employees, including their families, will be offered psychosocial support through our EAP program. And all cases will be investigated to make sure that contact tracing is done. In this case, we had about 8 possible contacts, and all of them were quarantined for 14 days at that time. And they all came with a negative lab test. The reason for that is that with our protocols, we are very clear to say we are going to follow the test-based approach. Irrespective of what the guidelines were saying, for us, we said we are going to follow the test-based strategy. And the reasons for that is that most of the areas where our guys are working, the social distancing in other instances was impossible because they work in teams. And if you are having outage and or you have to service a boiler, people have to work together. Yes, we will provide PPE. Yes, we will make sure that we look at time intervals, but social distancing in other areas was a challenge. That's why that's why that was our approach. And on the 11th of June, from that date when he tested positive, the guy was booked off sick until June. And for the 30 days that he was in the hospital, 10 days was in an isolation ward, 20 days was in ICU, and of which 8 days thereof, he was intubated. Upon discharge from the hospital, he was further given 15 days of 15 days recovery period at home. And he provided us with a letter to return for duty on the 30th of June 2020. When he returned, automatically we did fitness for duty assessment, but we realized that things were not as we wanted, and we referred him back to his treating doctor for further management. And after securing the appointment with the treating doctor, he was further given further sick leave from the 1st of July to the 4th of August. And on the 3rd of August, we received a letter again, for a medical report from his treating doctor to say that he's symptoms free and he's fit to resume his duties. And on top of that, we noticed that he's also diagnosed with hypertension and major depression. So therefore, he was also newly diagnosed hypertension and also depressed. So we have to say, what is that we are going to do? What fitness for duty approach are we going to take? And that's what I'm going to take you through. I always say, remember, as occupational health, we are working in a very legislated and unionized environment. And as an occupational health person, you always have to ask yourself the following questions. And I always say, when you are faced with a problem or you are doing anything, ask yourself, why are you doing it? What is it for? When, where, who is going to do that? And if you see all the what's, what, where, there's an H in front of it. And you have to ask yourself, how are you going to do that? In this environment that you are in, right? Remember, every decision that you are making has got an impact on the employability of the employee. So if you are going to say the employee capacity is not good, he has to be accommodated somewhere, the employee has got the right to challenge that decision. And if the incapacity says the person is totally impaired and they have to lose their job, that case might end up in the CCMA. So that is why it's very important that you, as an occupational health person, you always make sure that you answer those questions for every case that you are going to do, especially the reason why. Why is the person referred to you? Why am I supposed to do this? And I know that Greg has covered the other areas where if it's legislation, you have to make sure that, yes, you are following legislation and you are clear of that, what is that you are doing. And or if it's section 2 or section 8 of either this Health and Safety Act or the Mine and Health Safety Act, then you need to make sure that is a duty of care of the employer. And you need to make sure that you explain that to the employee. The questions to answer is, what is medical fitness for duty assessment? And why should I do it? And when should I do it? Where should I do it? It's very important. Again, you can't be doing it in offices. It has to be in a clean medical environment, a health environment, where you can be able to, because employees will quote you and say, I was in an office, he never touched me, he did not do anything. So you need to be careful of those shortcuts. And who should do it and to whom, right? And how do I do it? Or how did I do it? That's what is important. What test did I do? Did I take history? What is that I did? And what are the outcomes? And how did I communicate them? So those are the things that you need to make sure that you are able to answer if you are having a case in front of you. Now, again, what we need to take cognizance of is that occupational health has moved from just fit for task and risk-based only approach. It has moved to a more comprehensive multidisciplinary approach. You cannot sit on your own in your office and say, no, it's fit for task and risk-based. You also have to say who else can assist us in making sure that the employee is fit for task and fit for location. We need this holistic approach to managing these cases. And we also have to consider the employee's mental, physical, and social well-being general health and personal development. You can't separate the two. You can't just look at the mental and physical and not touch in other areas. And remember, COVID also has made us rethink the provision of occupational health services. With us, by the time in March, we had already suspended most of our screening services, because the risk assessment that we did, we said we are going to suspend vision testing, we are going to suspend lung function tests, we are going to suspend audio. And the reasons for that were based on our risk assessment. And we further said, what are we going to do when we have cases? And we came with a conscious decision that we will only consider cases that needs to go for diagnostic purposes. So we have still suspended our screening test to date. And what is medical fitness for duty? I always say that it's a process, it's not an event. That where you seek or gather information about the employee's mental, physical and social well-being, general health and personal development. And you might use a medical questionnaire or full clinical assessment. And by clinical assessment, I say you start with that history taking, you do your vitals, you do physical and mental examination, and do clinical tests where possible. If you can't do those, then refer to the relevant treating doctor for them to do that for you, right? I'm not going to touch why we should do the medical assessment. I think Greg has covered that in details. What I'm just going to highlight is that I always add the third bullet where we say you also have to check for fit for location. We always check on the task. We always check whether there's a risk or not. But sometimes we don't look at fit for location. I'll give you an example for fit for location. You might have a person that is on dialysis, right? And you are able to say the person can complete their tasks. They are fit. They are fit to be. They are fit for task without any risk to the health of themselves and other employees. But the person is based in Lephalale, in Medupi, and he has to go for dialysis 3 times a week. And you don't have the renal unit in Lephalale, in Medupi. So this person has to be 3 days in Johannesburg doing dialysis. And when he tries to travel in other days, he's got complications post-dialysis. So therefore, you are basically having a person who's not working at all in the Lephalale. So fit for location, it's something that we as occupational health fraternity needs to start looking at and giving an opinion to say, though this person is fit to complete their task without risk to their own health and safety of themselves and to those of others, but they are unfit for location. And that is very key. I'm not saying you should tell the employer what to do, but you should highlight the importance to say, this person is not fit for location. And coming back to my case, to say, when should we do a medical fit? When should we conduct a fitness fit? If it's for COVID, our approach was simple, is that the employee should have been isolated and de-isolated in terms of the Department of Labor, Department of Health de-isolation recommendations. So because the employee was diagnosed with COVID, obviously they had to be isolated. So if that process has not been done, then it means that the person did not get maximum treatment and or being treated at all. And we always said de-isolation is not the same as recovery. And that is why probably we are now talking about post-COVID syndrome. So de-isolation was more about the infection, the infectiveness, whether the person can infect, not that the person has recovered. And if we can take that and start internalizing it to say, when you get a sick note or a person is de-isolated, does it mean that the person has recovered? That's why in the workplace, that's when medical fitness for duty has to come into being. And the other thing will be, while you are making your plans especially around return to work strategy of your organization, whether you've adopted the test-based approach or the non-test-based approach or the dual approach. The test-based approach is where you are saying as an organization to say, if the employee comes back, we are going to need a negative test. I understand that there will be protocols from government to say you shouldn't, you cannot, or else. But we did our risk assessment in our areas. If you look at Quebec, which is our nuclear power station where there's outage, we needed to make sure that everybody that gets in there, it's negative. And we also have international people who are coming through. And we can't risk to have any day on some of these specialists not being on site. So therefore, that's why our test-based approach, the strategy, had to be implemented in that area. We understood the capacity of the labs not to do some of the tests, but unfortunately, from our side, we had to keep that as our strategy. The non-test base was also there for some categories where we say if a person has been isolated or quarantined, they can come back. They can come back to work, right? But that will be after isolation without a test. But again, that was risk-based. That's why we said we adopted a dual strategy. When the other thing is that we were also strict by saying employees who have been off must be discharged by their doctors or their treating medical practitioners, either through a medical report and or a medical certificate, because you cannot have a person who's booked off sick and he was not seen by a healthcare professional. So that was avoiding a situation where people will just self-isolate and or they claim that they've got COVID without any proof. That's why we said every case had to be supported by the lab results. And obviously, for you to have lab results, you should have consulted with a doctor who would have written and or requested the COVID result and got the results thereof. And the third one that has always been there, though with COVID, we said we suspending that. It's when the employer believes, it's when the land manager believes that the employee is not physically well or is a danger to others. And I deliberately highlighted the word believes because it should be objective. You are not going to get a line manager that just believes without any objective evidence or anything that is tangible to say, this is what happens, that's why I am referring an employee to you. You need to always make sure that you do not take any patient, any employee, right, where there is no clear evidence of a danger to himself or cannot perform their duties. They must always give you that clear evidence. The employee came back after we've received the letter from the doctor and we did our fitness for duty. And now the question was, who should do it? In our area, we said, anybody that has been hospitalized and classified to be having a moderate to severe COVID, an occupational medicine practitioner will do that medical, and or where possible, the occupational health specialist will be consulted. And all the mild cases will be done by the occupational health nurse. And where all the asymptomatic cases or people with mild cases do not improve or do not recover within 20 days, such cases should be referred to an occupational medicine practitioner so that we must also deal with post-acute COVID cases or post-ICU syndrome cases as soon as possible, right? And how did we do it? And I think the how is what is important because there are people who can always query how you did your test. And you always have to be objective and be open to the employee to say, this is what I'm going to do. We have developed a COVID-19 questionnaire where we made sure that we try to cover almost all the things that we knew about COVID. And this document, we update it every time when there's new information regarding the signs and symptoms and other things that we need to consider for COVID. And it's in such a way that when somebody completes it, it can give you an idea of what is happening with the employee. And that is done by the occupational health nurse, as Greg has covered in his diagram. The occupational health nurse will make an appointment, and we also try to make sure that this should be virtual where possible, so that at least there must be that human interaction where you make an appointment. If somebody can go into MS Teams, you are able to talk to them and say, this is the questionnaire, this is how I'm going to help you complete it, and or if you don't understand, these are the things. Try to make sure that in this time and era, you also try to have that human interaction. But where it's not possible, telephonic or electronic form can be sent through to the employee. And the way the form is designed, like I said, it's in such a way that it enables us to determine the outcome of fitness for duty and or whether there is a need for a face-to-face consultation. And in this case, when the form came back, we noticed that the employee was complaining about dizzy spells, episodes of tight chest, shortness of breath, and he was afraid that he was going to die and was worried about his family. And by that time, it was an indication for us to say something is not right, even though the person has been declared fit for duty. And that's when we said, let's have a face-to-face so that we can be able to see how we can intervene. Because remember, at that time, his treating doctors have already discharged him from their treatment. And when I saw him on the 30th of June, the complaint from the history taking and the complaint, the employee said, felt fatigued, difficulty in concentration, spells of dizziness, temporal headache, joint and muscle pains. He couldn't sleep, tight chest, and shortness of breath. Though from the clinical test that we did, the respiratory rate was okay at 20 breaths per minute. The pulse was 98, though normal, but on the higher side. The blood pressure was high actually at 168/103. But he said while he was in ICU and in the hospital, the doctors decided against treating it. They were still monitoring it. And his AGT was about 7. His temperature was okay at 36. And his sets through the pulse oximeter was around 95. And when I examined him, his chest was clear. His cardiovascular system was fine. And neurologically, he looked intact. But based on his complaint and the blood pressure and the sets of 95, I decided that I'm not going to declare the employee fit for duty, right? So I said the employee is fit, it's temporarily unfit for work. And I use the word temporarily purposefully because I'm saying it means that we have not reached maximum medical treatment. So therefore, I was going to refer him to be further treated. And once you are there, obviously the employee qualifies for a sick leave. Then I made sure that I consult with his treating doctor immediately to advise him on my findings and that the patient needs further treatment. Fortunately, they were receptive, and I also consulted the physician who was seeing the employee, and we were lucky to secure the appointment the following day. And I communicated with the line manager to say the employee is going to go to see his doctor, and he must consider giving the employee sick leave upon receipt of the sick note from the treating doctor, and that the employee will only return to work after the next fitness for duty. And after that, we receive a sick note again that's booking the employee from the 1st of July to the 4th of August. And the employee was still in our case management panel. And we followed up, and when we followed up, we found that at least at that time, there was a multidisciplinary team that was seeing the employee. So it was the general practitioner concerned, the pulmonologist, the neurologist, psychologist, psychiatrist, and occupational therapist working together to try to assist the employee. Then on the 3rd of August is when we received again the medical report from the treating doctors to say the employee's condition has improved significantly, though he has now been diagnosed with hypertension and depression. And he will benefit from being allowed to come back to work. So we did a fitness for duty assessment again on the 5th of August 2020 through, again, a medical questionnaire and face-to-face consultation. And our outcome for that was that the employee is fit for work with restrictions. So therefore, we said there must be temporary reasonable accommodation, which included the employee working from home. Remember, this was a category 1 employee who was expected to physically be at work. Then we had to change him from now to be a category 3 employee who was not supposed to come to work. And the employer, we sat with the manager and say, now that we have got an employee who has not recovered, how are you going to accommodate him? And a job accommodation was recommended. And we realized that at least he could do 40% of some of his job while he's at home and virtually. So therefore, as we speak, the employee is currently working from home until the 30th of March 2021. One may ask me, why did you say 30 March 2021? Our approach is not the levels of intervention of the lockdown. We are saying a pandemic will have a pre-pandemic, during pandemic, and post-pandemic. And we are only post-peak. We are not post-pandemic. So therefore, we are saying we think that this pandemic will be with us for almost a year. So that's why we are giving this person enough time to recover until the 30th of March 2021. Though we will keep on, he's still in our case panel. We're still communicating with these doctors just to make sure that as they see him on a monthly basis, they give us feedback on whether there are any improvements.
Dr. Ramanzi, apologies for interrupting. We'll have to conclude in the next 2 minutes as there's another session starting at 1 o'clock. If I could ask you maybe just to wrap up on this particular case study. Thanks.
Great. So the question will be, what is next? What is next is that we are going to do the next medical on the 1st of April, where we are going to consider all the things that and the new developments that are there in medicine. Heart rate is one of the things that we are going to make compulsory for all the employees coming back, blood pressure, lung function, and we'll also check whether their doctors have done an ECG. We'll also do a mini mental questionnaire, and we'll also check, because one of the things that I picked up from Prof. Guy Richards is that some of the patients that come from ICU, they do a chest X-ray after 3 months. So probably we'll also include that as one of the requirements, just to make sure that we are all aligned. And thank you.
Well, thank you very much. That is Dr. Muso Ramanzi, the occupational medicine practitioner and chief medical advisor at ESCOM, dealing with medical assessments of an employee returning to work post-COVID-19 illnesses. And on that note, I need to conclude and thank all of our presenters, Dr. Guy Richards, Dr. Sandra Fernandes, Dr. Greg Kew, Ms. Tia Marie Hofmann, Dr. Jack van Zyl, and finally our last presenter, Dr. Muso Ramanzi, for your contributions. And then specifically to Dr. Spoor Galamono, she has been very critical also in ensuring that your questions are answered on the Q&A. Dr. Spoor has been our executive director here at NIOH until Dr. Mzukulu Zungu had taken over the position on an ad hoc basis. And then to our team of panelists, that is Samantha Yalu, Sayuru Pillay, Anna Furi, Gabriel Mizan, Jeanette Mangani, Nompumelelo Ndaba, Odette Volming, all of our colleagues for contributing to answering the questions online. And on that note, thank you, everybody. Thank you, Dr. Fernandes. I conclude this session. Please be reminded that you can go to our website and all of the presentations and video and audio recordings will be found there. Thank you, everybody. Goodbye.
Thanks, Ashraf. Cheers. Thank you. Bye.